Specialty CPD. This Saturday, the 13th of December, is the second session of the two-day CPD program. And I'll welcome you all once again. On today's session, we are going to hear presentations from senior clinicians and academics, starting off with Dr. Olajide Oloye Olubanji, who is the Deputy Director of Physical Therapy at the National Orthopedic Hospital in Dala, Kano. And he has more than 2 decades of continuous experience in clinical research and in the management of orthopedic conditions. And we are going to have a presentation from him today. We are also going to hear from Associate Professor Dr. Awal Muhammad, who is an Associate Professor of Neurophysiotherapy here in Bayero University, Kano. We're also going to have the second part of the presentation from Professor Umar Muhammad Badaru, who is the chairperson of the Education Committee of NSP Kano, who was unavoidably absent last week. So we're going to hear his own part of the presentation that should have held last week, and we're going to hear from him today also. So currently we have about 12 people only in the audience. So I feel it would be much better if we waited just for a little bit to have a few more people join in before we commence the presentation proper. So I crave your indulgence and I apologize on behalf of those who are yet to join, for those of us that made sure to join early. So let's give them a few more minutes before we can start the presentation proper. Thank you very much for your patience. Good morning once again, ladies and gentlemen. We are currently at 16 people within the audience, so we're still waiting for a little bit more people to join so that we can comment. But nevertheless, we will be starting by 10:30, inshallah. So we apologize for the delay. Good morning, ladies and gentlemen. Once again, we apologize for starting the workshop rather, at this time, nearly 30 minutes after the announced commencement time. However, our first presenter is currently online in the person of Dr. Olowe Olajide Olubanji. And as I've said earlier, Dr. Olubanji is a deputy director of physiotherapy here at the National Orthopedic Hospital, Dala, and he has well over 2 decades of experience in research and clinical practice. And he's here to present on an important aspect of pain regarding the musculoskeletal system. And Dr. Olajide, if you are ready, the floor is all yours. You can commence. Thank you very much, sir.
All right, good morning, everyone. I want to thank the organizers for. I hope you can hear me, Dr. Seva. Just let me know
Yes,
whether
sir.
you
We
can
can
hear.
hear. We can hear you, sir.
Okay, all right. Due to some a logistic problem, I'll say, I didn't get to know that I was supposed to present early this morning. Though I'm actually ready, but it's just for some few things to be okay. You know, from the topic that was given to me, I was supposed to discuss appendicular skeleton and exoskeleton pain management and red flags. So while I'm trying to restart my computer, I'll just give us a brief of how I'm going to go about the presentation. All right, please, at any point that you cannot hear me, maybe because of a network failure or stuff, you can just let me know. While my computer is restarting so that I can be able to share my screen, I'd rather start by presenting on red flags first and the differential diagnosis of old axial and appendicular skeleton pain so that we won't have so much to grab with when we're discussing the management of axial skeleton pain and the appendicular skeleton pain. So if we have discussed the red flags first and we have talked about the differential diagnosis, we're going to have an easy flow while we're discussing the management, the evidence-based management of the axial skeleton and the appendicular skeleton. Well, from my experience, while my computer is still restarting, please, from my experience, management of pain or diagnosis of pain or management of axial skeleton or appendicular skeleton pain, one of the major important factors that I actually put in my practice is to make sure that diagnosis is right at all times. The moment diagnosis is never right, then whatever you are doing for that patient will never bring about any fruitful or how do I put it now? The patient might not benefit from your intervention. And for your intervention to be fruitful and to yield the desired result, your diagnosis must be right. So that's why discussing red flags and differential diagnosis as for the start will be better for, I think will be better for everybody, the newly graduates, the older ones, and the professors among us will bear me witness that. And by way of saying, I would like to say that everything I'm going to say about the management of pain in exoskeleton and appendicular will not be everything there is to it. But this is a kind of lecture that should be taken for like 2 or 3 semesters if you're supposed to cover it all. So I will only be saying the most basic things I think we can do as new graduates, as people that have seen musculoskeletal conditions on daily basis. Either you're a neurological physiotherapy, you specialize in neurology, cardiopulmonary, or any other specialty in medicine. Musculoskeletal pain will always arise. It is the anchor of, of the body system. It is the musculoskeletal framework that carries every other system around. So if there's problem in any other part of that system, there is going to be it's going to reflect on a musculoskeletal framework of our body system. So everybody must have managed musculoskeletal pain irrespective of where you are in your practice or in your specialty at one point or the other. Like Professor Jibril said last Saturday, we have pain mimicking a back pain that comes from internal structures around the cardiothoracic region. We have pain that mimics back pain that comes from the abdomen. And we have pain, that be mixed back pain that comes from the ups and gynae area for both and female, for both male and female patients. So we can see that management of a musculoskeletal pain cut across every other part of a physiotherapy specialty, which is actually an important aspect of physiotherapy. I was thinking I won't be able to do this alone, and I would like every other person that have one or two things to say after I've finished delivering what I have to be able to contribute and be able to enlighten us, because knowledge is never static and no one single person knows it all. Okay. So while I'm still waiting to be able to share my screen for you to see, I would say red flags. It has been talked about. It was talked about a lot last week, Saturday. We need to actually screen red flag because of certain reasons. Number one, I'm just going ahead of myself because my screen is not up. Number one is because of the fact that throughout the whole world now, like physiotherapists are serving as first contact practitioner, especially in the management of musculoskeletal pain. We are being entrusted with the responsibility of actually making diagnosis that we can manage, and the one that we think we cannot manage because of suspicion of red flag, we can actually refer. So I think we have come to a stage in the life of this profession and in Nigeria where we need to actually bottle up and make our presence known and felt. And we cannot do that until we are equipped with the right knowledge to be able to triage our patients properly when they come visiting us, especially at the primary care setting. I'm very aware that there has been a lot of things being done on the ground about how to implement rehabilitation practice at the primary care level. And we need people that are more knowledgeable to be able to do that. People that know what is all about the care of musculoskeletal system, to be able to do that, which is a major body. Management of musculoskeletal is a major body within the health sector, as we can see. Back pain, knee pain, shoulder pain, neck pain, they are more burdensome. We see them a lot in the clinic than any other kind of in physiotherapy clinic, let me say rather, than any other form of pathology that usually come to for. And in primary care setting, I can be rest assured that we're going to see more of that, especially physiotherapists are supposed to be working in that particular area. And by way of red flag, I wish I can share this with, but the computer is still here to come on. And I'm sorry for doing this early. I don't like to do stuff like this, but I didn't get to know that this thing will come up so early like this. Red flag is just a suspicion of something much more than what we think the patient is presenting with. It's a suspicion. It's not as if it's a diagnosis. It's not as if it's never labeled as a diagnosis. Red flag are just suspicion, which can be clinically using our own assessment to actually triage it to be true or not true, without referring the patient for any imaging technique, any further biomarker workup, blood workup, so that the patient does not spend more. Out-of-pocket expenses can be cut down if we are well trained to be able to recognize red flag, even as the patient is walking in, isn't as if they started talking to us. Immediately they start saying things that we can actually pick to be a red flag, or we can see on their faces, or we can see from their body expression of what their source of pain will be like. And even before they approach us, normally we have to therapists, we look at our patients when they walk into our cubicle for treatment. Right from where they are walking in, I'm very sure, I've taught everybody, I was being taught, but that's how to actually look at a patient. When your patient is walking in, either with a caregiver or not, you look at how your patient walks in into your cubicle before how he manages to sit down on the seats provided, before he even say one thing. Your imagination will have run through and you will have processed a clinical reasoning within your mind of the possibility, and looking at the folder before you, the possibility of what could be wrong with that patient. even before the patient opens their mouth to say anything. And during the process of interrogation, which we call clacking, we could be able to pick one or two things, the way the patient described the pain, which I call verbal descriptor of pain, and to be able to check whether it matches with what some of the things I'm going to tell us about this red flag. You know, if it matches those things, we can suspect red flag and we can actually triage the patient appropriately. Whether we're going to go ahead with our treatment, whether we're not going to go ahead, whether we have something in mind to be able to offer the patient without aggravating the red flag. Sincerely, when I was looking at the red flag, when I was trying to look through the literature, it was like, when you see red flag, don't just do anything and just send the patient to for imaging or send the patient to a GP or an orthopedic surgeon or somebody else, or just send the patient for a medical referral. And in my own opinion, I don't think when we suspect a red flag, nothing should be done for that patient. And that's why we are specialists. And that's why I said earlier on that working in primary care setting, we need more knowledgeable physiotherapists that have more knowledge, that is well grounded in the management of musculoskeletal conditions and other conditions too, to be able to know when and what to do and at the right time, and when not to overdo and when not to underdo and shortchange the patient. Because we know the way things work around here, before the patient move from wherever they are to the bigger hospital, and for the patient to even assess the treatment procedure within the bigger hospital, there's a lot of barrier that patient faces that doesn't allow them to access care easily, even in the bigger hospital, like teaching hospital, specialist hospital. A lot of obstacles are put in their way before they can even assess, and that's where most of the quackery comes in. People want to offer them respite just because there are obstacles that will make them not to be able to access care. And I would like to say red flag, as said earlier, is not actually a label diagnostic procedure in itself. And at the same time, one red flag should not deter physiotherapists from seeing your patient. From what I've been able to look through the literature, sorry I couldn't share this computer listing, but I'll make sure I share it so that everybody can see. From what I've been able to read through the literature, we need clusters of red flags to be able to ascertain that a patient has a red flag. If a young man of 20 years old walks into your clinic and says he's having a sleepless night because a kind of neck pain, troubling neck pain is preventing him to sleep, that is not enough red flag not to see that patient. That's not enough red flag. If a 50-year-old man walks into your clinic and says he has been having a troubling pain that wakes him up at night, and when he wakes up and he sees that he's sweating and he couldn't go back to sleep again to daybreak, and he has seen that he has started losing weight, unless as in he has been eating well, he has every other thing under control, but he sees that he has been losing weight and he doesn't know why. And there are some other changes that he has seen in his body system that he thinks was not actually there before. Then we can suspect a red flag. And that doesn't still mean that we should push our patients out and send them for imaging techniques, because quite a number of therapists have been doing that, which we think we can do. We can send our patients to do MRI, to do CT scan, just to rule out a suspicion. But we all know how costly those imaging techniques are now for anybody to be able to do. So I'm thinking as physiotherapists that work in primary care and even in the tertiary care, we will need the knowledge of red flags to be able to assess and manage their patient very well. And attaching it to differential matches, because the moment you are looking for red flag, you are actually really looking for differential diagnosis like that. You want to separate which of the pathology you think is happening or is not happening within the system. Okay? Within the system. So we need to be grounded, but we cannot take it wholesomely that red flag is something that should deter us from seeing our patients. And for differential diagnosis, from a systematic review that I saw, I would have loved everybody to read, which was published in 2025, looking at a red flag vis-a-vis clinical guidelines, there was no concrete evidence to say clinical guidelines is affected by the presence of red flag. That was their conclusion. That was their conclusion. There was no any significant relationship between red flag and the clinical guidelines that we proposed over time when they look at studies that were done. And it was a 2025 study that's been published. If I can still remember the name now, I think it's a statutory. Oh my God, it's not coming up. Statutory, it's all 2025. Okay. So if you look at the clinical guideline for management of neck pain, for management of back pain, low back pain, for hip and knee pain, well, on top of the evidence is that conservative treatment, which physical therapy is part of, to be the first line of treatment in any part of the world, and where over-the-counter medication is allowed minimally at the very best. So I know we have a lot of things to offer. We have a role to play in the management of these conditions if we are well prepared, if we are well positioned to be able to actually identify, know when to refer, know when not to, know when what our modalities can work, and know when to discharge the patient at the same time. To discharge the patient at the same time, because our ability to be able to recognize this red flag, well, in my own clinical practice, has actually helped me to make proper diagnosis, to be able to reject patients, to be able to send patients back to wherever they are coming from any referring surgeon. And I would like us to know as physiotherapists that sometimes patients are abandoned or have been sent to us when the surgeons want to let them go. They just want to offload them and get them out of their clinic. I've had several cases of that. Or maybe because I was vast in knowledge enough to be able to know that whatever they have sent this patient for, what is presenting before me is actually far more than what they wrote on paper. I'm telling you the truth this morning. What they usually write on paper, when you look at a patient, without saying anything, I've sent patients back several times that whatever they wrote on paper, what I'm seeing, excuse me, what I'm seeing in front of me actually is more than that. And it has proven to be true. And that's when we were respected, and that's where the respect comes in. When other professionals, other prescribers knows that when patients are sent to you, you are able to recognize what and what is wrong, and what you should not do, and what you can do. What I'm saying is not patients that we're supposed to manage, especially when red flag is concerned. If you recognize it and we see that it is very serious, it will affect whatever we do. And if whatever we're going to do will affect or will worsen the condition, then we should let the patient go. We should let the patient go. If any patient that walks into our clinic should work out better than they walk into our clinic. So the essence of red flag is to, for me, as the way I look at it, is to protect us, to lift our image, to let people know that we know what we are doing and we won't do more than what we have been trained to do. So identification of red flag is one thing that I find interesting. I'm so sorry, participant, that this computer is still putting. I don't know. I would have even shut down in the first place if I knew that I'm presenting this morning. No, I don't know if you can. Well, Dr. Sefa, can you give me like 5 minutes to pause and let this computer come up?
Okay,
Hello,
sir, we
Dr.
can.
Sefa. Can you give me like 5 minutes so that this computer can
Yes, sir.
start properly? I would like to share my screen
Okay,
because this red flag
okay.
and differential diagnosis, I would like everybody to be part of it. But that's the basis of
Okay.
this discussion. Because the moment we cannot make the right diagnosis, then our intervention cannot be okay. And this is going to help us a lot. Identification of red flag vis-a-vis differential diagnosis. That is exactly what I want to say about this red flag, not just red flag. Can I pause for like 5 minutes? I can see that it's saying it's restarting so that I can be able to share
Yes,
this.
sir.
Okay, now please, I
Go
crave your
ahead, sir.
interruption. Okay, okay, thank you.
We apologize, ladies and gentlemen. Dr. Olowe is trying to come up right now to sign back in so that we can properly see his slides. Initially, he was having technical difficulties trying to share his screen with us, but he's restarting the computer to ensure that it comes back on and it works properly. So let's exercise patience, please, for a couple of minutes. Thank you.
Hello, Dr. Sefa. Hello, participant. I hope you can hear me. Well, even if I can't share the screen right now, it will have been corrected before our next
We can hear you, sir.
presentation. Okay, so the PowerPoint is opening up. I can complete the red flag presentation, but I'll still try to share the screen if this Zoom, if I'm able to open it on my phone, because I'm using my phone to actually design this. I can look at the screen, I can look at the PowerPoint from my computer, and I'll just continue, and I'll make it available for everybody to it's opening up, and I'm able to present it appropriately in the way it comes up. Please, we're sorry, it's not in our character to be like this as professional, but sometimes things like this happen, especially when technology is involved. And that's what we are saying, identification of red flag when we need to use technology to do certain things. Technology can never replace the place of physiotherapy or physiotherapy in the management of patients, and even if it can in any other, because we need, our patient need direct touch, they need direct supervision, they need direct instruction on how to do whatever we ask them to do. So just bear with us. And I feel as Kano State NSP, it's not in a character, and we're going to do better next time. Please. All right. For all the participants, the topic is actually pain red flags, indication for medical referral in patient with an orthopedic condition. So we should know that it's not only in axial and appendicular skeletal pain, every other orthopedic condition that we can actually think of. All right, to put in a proper perspective, while I was trying to give us the definition of Dr. Sefa, I'm already moving. Is that okay? Hello, Dr. Sefa. Are you around
Yes,
there?
sir. Yes,
I
sir.
should go
Please,
ahead, right?
you may continue.
I should
Yeah.
I should proceed, right?
Yes, sir. But I have a suggestion. Can you maybe send the slides to me so that we can share it from my end?
Okay, I should send it to your WhatsApp page.
Yeah. Yes. We'll have somebody else share it.
Sharing. Okay. Then let me just pause on it. All right, Doctor, you say it is sent already.
Thank you, sir. I just received it. I'm trying to
Okay,
bring
thank
it up.
you. Okay, fine. Thank you so much.
Okay, the slides have been
Okay,
shared by.
I can go ahead now. Okay, thank you so
Yes.
much. Thank you. Yes. So the topic is ten red flags, indication for medical referral in patients with acute condition. Put it in a proper perspective, like I rightly said. Okay. And the reason why it is important is because of the growing role of direct access of physiotherapists all over the whole world. And that's one of the few reasons why we need to actually develop skills in identifying red flags to be able to have a proper differential diagnosis of orthopedic conditions so that it will not jeopardize our work. From the study that I put there in slide 2, talking about the standardized definition of red flags in musculoskeletal care, a comprehensive review of clinical guidelines. Their basic conclusion was that RF criteria varies across clinical guidelines and lack consistency. So what that tells me is that we should not rely on red flags alone not to see our patient. If it lacks consistency across various clinical guidelines, that is not something that we can just rely on. We can rely on it first for us to have a safe practice, but that does not jeopardize why we should not see our patient and this provide care for them, even when red flag is actually present. That's the pattern driving into. And for the stuff that I put in red, with the growing role of direct access to therapy bypassing physician referral, therapists must develop strong differential diagnostic skills to identify serious pathologies that may mimic MSK disorders. That means why we have learned all the things that we have learned in school about the management of orthopedic conditions. We need to go further to learn about other systems that mimic, and we should have a direct shot to be able to identify these systems mimicking orthopedic conditions at a glance, even when the patient has not even sat down properly to tell us anything, which I think that's the hallmark of being a professional. And that's what the young graduates should look forward to be able to do, not just wanting to start practicing, and while the older ones should be able to guide them through. All right, we'll move forward now. Across both CG, clinical practice and systematic of guidelines, a consistent optimization of RFs emerges according to which RFs are clinical features that allow the clinician to the potential presence of serious underlying pathology beyond typical musculoskeletal condition. That means as physiotherapists, we must know how a particular musculoskeletal condition presents and behaves, and how patient describes them personally. Well, for young graduates, you might not have had enough experience to be able to know what patients says about particular condition. But for those of us that have been in clinical practice for a long time, we could practically say that this is what, if somebody is having this kind of condition, this is how they are going to describe it. And it has always been so. I can tell you of several patients that I've seen. The stories are always the same. They are going to tell it the same way, and they have never met each other. And that's how good it could be if we listen to a patient, if we look at them carefully while we're trying to manage them. RFs may include subjective comments from the patient, specific signs that are observed by the clinician. So while the patient is talking to you, in anthropology, they call it explanatory model. While the patient is talking to you about what brought them to the hospital, and that's why we need to listen more, we could pick some comments in form of verbal descriptor, which I'm very sure is the next slide I'm going to know that whatever has brought them to that hospital has an element of red flag in it, so that we can be careful. Not that we're not going to provide care, but just for us to be careful about the kind of care that we provide. And when I mean care, even starting from a test and measurement, we could do some tests that could aggravate the red flag right from the onset, and the patients never want to come back, or they keep talking about us in a bad light out there. The primary purpose of identifying RFs is to guide decision making regarding the need for further medical imaging, pharmacological, urgent surgical intervention, or referral to other healthcare professionals. Well, this is not a weakness if physiotherapists have to refer patients to other healthcare provider. And I think it's even a plus for us, because I've done this several times, and I won't lie to you, it has helped me accolade. Because what you think you cannot do, and you have the courage to send the patient to somebody else that you think could do it, it's a plus and it's a strength for you. And other people will respect you for that. Sincerely, I've had a patient that it was a young boy of, I think, 6 or 7. This father is an orthopedic surgeon in this Kano that went to school and fell. And what he could already do for that small boy is to call TBS to do something for him. And the father was far away, he was outside of Nigeria. By the time the child started manifesting some musculoskeletal pain and the rest, and they came to the hospital, after like 2 weeks of treatment, that's about 6 sessions, I discovered that no, this cannot be an ordinary mechanical pain. But from my own perspective and knowledge of physiotherapy, any mechanical pain, musculoskeletal pain, will respond to our intervention within the first week or 2. And when I discovered that, I had to call the senior orthopedic surgeon to come and have a look. And by the time we finally found out what was wrong with that boy, the son of an orthopedic surgeon, he already had a mangled stripe of one of the quadriceps by the time they put on the table. It's already mangled, completely mangled. They have to resect and take it out, even while the father was not there. So the boy had to undergo an operation to take that, and that was the end of that condition. So it's better for us. The father was grateful at the end when he came back. But what I'm telling us is that it could happen. If that could happen to the son of an orthopedic surgeon in a place like this, and his colleagues were the one that referred the boy to me from HC, it will help us accolade to know when to refer, when to call in the next person, come and have a look. And it's not a weakness at all. The era of nobody knows it, on the era of saying we have to do everything, and no, we will learn as young graduates and as older physiotherapists, to know when to refer our patients when we discover stuff like that, which I think will earn us accolade in the long run. All right. Well, yes. While I was explaining why we should listen to our patients, there are some verbal descriptors that already that I look for, that when the patient is talking and describing their pain, when they are talking to us during clacking process, when you are hearing something like they cannot explain how it happened, when you are hearing something that the pain has been constant even after they've taken over the cancer medication, and when you are hearing something, the pain is worse at night and it awakens them from sleep. And when you ask them, how did it happen? They couldn't recall this. It was just a sudden onset. And it has been progressive or worsening. And they could feel there's an altered sensation of function in their body. And the pain, you now see that the pain is atypical. It doesn't behave. And it's not a phenotype of any kind of mechanical pain that anybody will feel. They can actually see that there's a red flag there, and we can triage the patient appropriately, either to see the patient and provide little care and refer for other people to see. Quickly, I want to tell us some few facts about RFs. Red flags are just essentially clinical prediction guides, which will never take, we should not take our clinical reasoning and ability to make diagnosis and actually formulate a treatment procedure away and actually providing care for our patient. They are not diagnostic sets and they are not necessarily the dictators of diagnosis or prognosis at the same time. If you have seen a patient that you think has a red flag, and maybe after providing the care for the first time, when the patient is coming back, you see that the red flag is no longer there. That doesn't mean the patient has gotten better. It's not a diagnosis and it's not a prognosis test. You still need to see your patient holistically and look at them carefully. And it is important to bear in mind that red flags represent a list of clinical findings rather than a set of that same thing. It's also important to retain a sense of perspective when examining patients, as only 1% of examined patients are suspected of having serious pathology. So talking about red flags, we won't go looking around for red flags because in how many patients we are going to see, it is being said that it's only 1% of those patients that will actually present with a red flag. And if you are working in larger hospital environment, in a tertiary institution, you could see it's only on a very few occasions that you see that patients with red flag will filter through that system and get to you. They must have been screened right from the first contact, which is either the surgeon or the physician. If the patient is able to filter through and gets to you, then it is your duty to be able to actually locate such patient and treat with care, not that you don't treat at all. All right, there's a mnemonics that I put on the right side here. It's called a tuna fish. I'm sure most of us know tuna fish. So be able to remember all the verbal descriptors I've talked about. If you just remember tuna fish, you can be able to know whether there's a red flag or not and walk around there. Slide 6, we have some visceral disease rivalry that mimics low back pain, which I've listed there, not to waste our time because I've already wasted time a lot. Peptic ulcer, pyelonephritis, pelvic infection or tumors, aortic dissection, and all that condition that Jibril told us about cardiorespiratory condition that mimic back pain last week. We should bear that in mind as we go on. Then in a differential diagnosis of this one is actually concerning neck and back pain. Fracture is about 5 to 6% of people that you see. Caudal equina is about 0.4%. That means it is not, that means spinal cord pathology is not traumatic. It's just about 0.4%. While infection will be 1%. Talking about that sooner. Abdominal disease, okay, I can't find the percentage. For malignancy, it's just about 1 to 2% that will mimic orthopedic condition. So it's in the area, it's not as if they are always available. It's not as if everybody that walks in to start looking for it. We should look for it along the line while we plaque our patient and do our findings. Okay? And I put for slide 10, for slide number 10, I put thoracic pain as a subset of red flag. You know, this presentation is supposed to be about neck, low back pain, then axial skeleton pain. For thoracic pain, we should not let it slide off. It's a subset of red flag. When you see a patient walking in plus other red flags, and it's the complaint that he or she brought is thoracic or mid upper back pain, your clinical reasoning should be up at that point to look for what could be causing that thoracic pain, whether it is more than mechanical, because it's a subset of RF, red flag, that we can just discard and think it's a mechanical bad. When you say patient with thoracic back pain, we should put all our clinical reasons in place to see, because it is more likely than lower back pain to signal serious motor, which can be an infection, a tumor, or herniated disc, or something coming as in projecting from within the chest region. Okay, thoracic pain and visceral pain can mimic the other due to shared aberrant innervation. That's the reason why I'm just stating the reason now why they can mimic back pain, because of there are different innervation of the autonomic nervous sympathetic system, which originate from T1 to L2, aberrant fibers from the spinal cord, and the other segment of T4 to T7. They have the potential to cause pseudoanginal pain as well as symptoms generated by cough, sneeze, deep breath, movement of the trunk, palpation, and compression. Whenever your patient comes in with a thoracic pain, which I put as a subset of a red flag, ask them to cough, ask them to sneeze, ask them to take a deep breath, ask them to move the trunk slightly before you palpate and before you compress. Those are the last things you should even do. Don't palpate, don't compress when the patient has brought a thoracic pain complaint to your clinic. All right, let me see. I'll move further now. Well, talking about differential diagnosis in patients with low back pain and upper back pain, I've listed them because we're still going to talk about them when we are talking about the management of this disease condition. As you can see, most of these conditions that are caused in the neck, they actually have a direct relation in the low back at the same time, except for, I think most of how it happens, because they have the structures are almost the same. The vertebral structures are almost the same. So whatever happens in the neck might likely happen in it's just that the difference is where the pain will actually radiate to is different. If it's actually if it has a compressive origin. So it's almost the same, and except a sacroiliac joint pain, which other joint? Except sacroiliac joint pain in the low back. Every other thing is almost the same. Then, right. Okay. Well, I talked about red flags for hip and knee pain. This one is actually straightforward. When the patient walks into your clinic and has this warm, swollen red knee joint, which actually signifies an ongoing bacterial infection. And if you palpate the groin and you see that there's tenderness around the groin, where there's an inflamed lymph node, you should know as physiotherapists that we don't need to do any rigorous stuff. We only need to just be tender with that patient, attend to the swelling, attend to other things, and send the patient to see the surgeon, especially if there's swelling in the groin. You should actually suspect infection or a process of malignancy going on. During your assessment, if you see a severe blocking of the knee joint, that's a significant joint dysfunction right there, which is not supposed to be. And if there's a true locking and giving way around that joint, it's a red flag. And if the patient says that there's always been a rapid swelling and pain with certain movement, like a scotting, you should suspect that something sinister is actually going on. All right, Dr. Safe, okay. Well, evidence-based practice. In evidence-based practice, what we actually looked at is a clinical experience of the person that is seeing the patient. We all need some younger colleagues who actually they are going to have this as they practice, as they pay attention to practice, as they grow in the profession. Evidence and research, we have scholars everywhere. We have done a lot of work around here in Nigeria, where we have ascertained what and what could be the cause, what and what could be the solution, what and what and exercise works for what in this environment, not going further outside. And what the patient values should actually be put in place. Even in the identification of red flags, it will still need the clinical experience of an older physiotherapist or a senior colleague. Any younger colleague that actually suspect anything, don't just discard the patient on your own. You can actually call your senior colleague to come and have a look. Second opinion is not weakness in any way, either from the younger or from the senior colleague. Anybody should look for second opinion when you suspect something sinister is going on, which you think is beyond, it's atypical. It is behaving differently than how the pain that the patient is complaining should behave. Senior colleague should you know one should call the senior colleague from our venue. And I can tell us that second opinion is never a weakness or whether you don't know what you are doing. It's just a safety net, a safety space for us to be able to practice effectively. Thank you for listening. I'm so sorry for this case, everything, but I'm sure as we go on, we're going to have a better presentation ahead. Thank you so much for listening. Dr. Sefa?
Yes, sir.
Yeah, I think I'm done with pain red flags and differential diagnosis or medical referral.
Okay, sir.
If anybody has any questions, contribution, they can actually put it up. Can I send the other slides to you too?
Yes, sir. Please go ahead and do so.
Okay, let me just send the other slides to you.
Okay, ladies and gentlemen, whilst we are working on the background to get the older slides started up, please, anyone with questions and comments can go ahead to either drop them in the comment section or raise your virtual. Assalamu alaikum.
All right.
Hello?
Hello, you can go ahead.
Okay, go ahead, please. Oh, okay. Good morning, everyone. Thank you for coming to the second segment of the presentation. I would like to commend a senior colleague, Dr. Jide, for the enticing presentation about the red flags, most especially in pain. So as a physiotherapist, I think it is a hallmark for us to be able to identify pain red flags. Why? Because they are essential so that we know the exact condition that we are treating, especially that he has highlighted that the pain can come from the viscera. So if you don't know the red flags, then you might end up just wasting maybe your time and the patient's time, of course. So it is essential to know the red flags so that we can know our limitation and then we can refer the patient to the appropriate quarters. Because the red flags, they are normally emergency situations. So whenever you see it and it's with beyond your scope of practice, then you can be able to refer to the next maybe healthcare personnel. So by and large, I can say it is a very good presentation. Thank you so much.
Thank you so much.
Thank you very much, Dr. Adamu. Anybody else with comments or questions? Please, you may go ahead and ask.
All right, Dr. Osefa, can I go ahead with evidence-based assessment and management of the pain in the exoskeleton? While we're looking at low back pain and neck pain. Can I go ahead?
Yes,
Like
sir, you
nobody
may go
said.
ahead. We're trying to get the slides running in the background as well.
Okay. Let me wait for you. Let me just wait so that you can get the slides.
And sir, please, whilst you are presenting, you may provide feedback so that we will be moving along with you, so that we will not be lagging behind or moving forwards before you finish the slides, sir.
Okay, all right. Okay. All right. I thank all participants for still staying with us while we talked about evidence-based management of evidence-based assessment and management. So in essence, there's evidence-based assessment and there's an evidence-based management of pain in the exoskeleton. We are going to be looking at neck pain and back pain. Okay? If you don't have an evidence-based assessment, you are likely not going to have an evidence-based diagnosis, like I rightly said initially. And if you don't have an evidence-based diagnosis, you can never have an evidence-based intervention, which will actually bring out about an evidence-based desired outcome. Okay? So, in all that we do, and in the management of orthopedic conditions, evidence-based assessment and evidence-based diagnosis is the key to us having an evidence-based desired outcome, which is pain reduction, improvement in functional ability of patients, especially better than the walk into a clinic or the walk into a hospital. Okay? I might likely not follow the synopsis as it is, but I'll just, I'm on slide 3 right now. I'm on slide 3, Dr. Seva. Let's talk about general assessment, physiological effect of acute pain, which is generally absent in a chronic pain. Okay? And why I chose this heading is because when we're talking about red flag the other time, there's nothing I didn't tell you. Sometimes people have acute pain that will have all the, go to slide 3, please. That will go to that will actually have all the ingredients of red flag in it. When people have acute pain, especially acute or chronic pain that's been there for a long while, you might be thinking they have red flag. And I'm going to let us see how that can be treated later on, which has been the mainstay of holistic management of pain in the recent time. People that are into neuro pain science, like Dr. Naziru, were able to tell us more about the holistic management of pain, in the essence of pain. You know, when people are having acute or chronic pain, sometimes they could tell you about they are having their heart is beating faster, they have been sweating, their breathing has been shallow, that's tachypnea, and a lot of they have not been able to eat well, or they have never been able to go to toilet well. You might be thinking that is a red flag, but it's just an acute or chronic background of pain that the patient is having. So red flag and acute or chronic kind of pain actually mimic one another, but because of the trained eyes and senses that we have, as well actually makes us to be better in identifying those signs and symptoms that patient could come with, especially during our assessment. I'm going to slide 4, I call it detecting pain and what pain behavior. Apart from verbal pain descriptors that I talked about the other time, we can actually see pain behavior, we can use pain behavior to actually know what and what's the extent of what is wrong with our patient, even before we do a test and measurement, would look like, you know. It was first described by Follis as denoting the verbal and non-verbal behavior. We're talking about verbal descriptors which we can pick from the patient's comment, but there are some other non-verbal behavior that you can see through and know that this pain, even without giving them verse to rate it on, you know that this particular pain that this person that brought this patient is actually far more than what they could bear. You know, they exhibited a lot of a lot of pain that they cannot even communicate. Some of them don't even know how to describe it. Some of them don't even know how to say it the way it is, the way they feel it. But you can see through it if you are really, if you are very observant and you have had contact with such set of people along the line of your practice. When a patient walks limping into your clinic, they cannot stand unsupported. People have to hold them up, not because they have fracture anywhere, but because of pain. You see them guarding the place, see them grimacing. They are hissing at regular interval, or they are moaning at regular interval. We know that that pain is unbearable and we needed to, I actually need to do something about that pain. So on that background, I'm on slide 5 now. Dr. Seva, I'm on slide 5. When we see pain that I've just described, the kind of painful condition that I've just described like that, we should suspect. That's talking about a red flag now. We should suspect something more can be happening, but that is not all. We could actually suspect that something more might be happening. And thank God I have a picture of what visceral dysfunction that mimics back pain should look like. Both neck and back pain could look like. And we have several body parts that have been depicted here. When the patient points to a certain part that they've been having pain there, and the pain has been constant, is not relieved by rest, and the pain is actually there at rest, even while they are not doing anything. We should be able to know, we should be able to have a clinical reasoning up to know that something sinister might be happening. So for visceral dysfunction, the red flags could be actually be pointed out when a patient is pointing to a particular portion of this of picture, as I have it here. Then number 2, most sources of axial back pain are from their structures, the soft tissue structure that actually hold the axial back pain in place. From our knowledge of anatomy, we know that axial skeleton is just a slender skeleton that holds every other part of the body together. And because of different forces acting on the axial skeleton, if the muscles, if the other soft tissue that is supposed to call them the active system that is supposed to hold them in place for us to achieve our daily activities are not optimal, if they are actually insufficient, if they are not producing sufficient strength, and if they are not able to form maximally under pressure, I'm talking about the active system now, which involve the muscles, the ligaments, all the soft tissue that hold the exoskeleton up. If the exoskeleton caves in under pressure, we might have degenerative changes that could occur, except trauma. If it's traumatic, there's nothing we can do about that. But degenerative changes, we could do something. That's when we have a preventive education that we usually give during World Physiotherapy Day, how people should remain active, how they should actually raise their physical activity level up, not because they are young or old. Everybody needs that so that exoskeleton can benefit maximally and will not cave in under pressure of what they are expected to do on regular basis. And part of the sources that I listed here is myofascial, tendinous, or ligament structure. Basically, the active system, basically are the one that usually have problem around the exoskeleton. Okay, the bone itself might not have problem except it is traumatic in a way. Okay, so you can have a discogenic myofascial sacroiliac joint pain, facet joints, all the joints that within the axial back pain would actually throw out painful sensation at one time or the other. If they are under pressure, if they are caving under pressure, or they are experiencing degeneration that comes with age as we age. Okay. Then for the cervical neck conditions, I put some. This is not all that we could say about neck pain or cervical dysfunction, but I just put some regular ones here. Patient could have upper cervical instability due to several conditions. They could have cervical arterial dysfunction. Cervical fracture could occur, especially in traumatic situations. Patient could develop cervical spondylosis. A patient could have ankylosing spondylitis, okay, which is an inflammatory condition that affects the joint, the whole of the joint of both the neck, the thoracic, and the lower back. Then patient can have cervical myelopathy when the spinal cord and other structures, central nervous structures, are actually affected. Okay, I'm on slide 8 right now. Well, how do we manage these cervical pain conditions? Well, I'm supposed to talk about how to assess them before the management. Sorry, how are we supposed to assess? What are the things we are supposed to look at? We're supposed to look at the presentation. We're supposed to look at their presentation. How does the patient present? What do they say about the neck pain? If you have ruled out red flag, and the essence of me talking about red flag is for us to rule it out. Let's just have something in our mind that what we are dealing with from this presentation is a mechanical cervical dysfunction. No red flag. We have ruled out red flag, and our patient is having just cervical dysfunction. How do we assess it, and how do we make an informed decision on our treatment? Since it must be evidence-based, we must look at, for scholars, for most of us, we are scholars anyway, we must look at what works. I've told us severally that infrared does not have evidence in the management of pain. Most of us still use it, but we don't use it in isolation, okay? We don't still use it in isolation, we do other things. Exercise has been the mainstay of management of musculoskeletal pain. And in management of cervical dysfunction or neck conditions, exercise therapy will still be the mainstay, because that's what most clinical guidelines have supported. But how do we assess? We assess looking at the patient, how do they work in? And since it is pain that we are talking about, we're not going to look at function. We're going to look at how they describe the pain. Is the pain radiating? Is it not radiating? Can they point to the exact spot where the pain is? When the patient can be able to point to the exact spot where the pain is, then your job as physiotherapist is very easy. They can actually say, I feel the pain just on the side of my neck. Sometimes the referral could come in form of cervical spondylosis. And what you see when you examine the patient or when you check the patient to tell you where the pain is that the patient have a trigger points all over. And I've managed patients like that, that a lot of them is just bifacial trigger points that brought them to the hospital. But the surgeon was actually managing the X-ray. And that's where where I would say we have an advantage over the prescriber or the referrers most of the time, other the physician or the orthopedic surgeon. Because they manage X-rays, we will manage patients. I'm not saying managing X-ray is actually bad, but managing X-rays will actually give you a false positive impression that the patient is having cervical spondylosis. Whereas if you pick 10 people of the patient's age and do an X-ray for them, you might have the same presentation on their X-ray. But why the remaining 9 are not complaining of any pain in their neck? And they are moving around looking for, as in carrying out their daily activities without being in the hospital. But for this particular person that has complained of neck pain and had come to our clinic, if the referral comes in the form of cervical spondylosis, most of the time, cervical spine, I don't think that genetic changes or genetic arthropathy of the cervical spine. I look at the patient holistically, and most of them I've discovered that most of these patients have malfacial trigger points all over upper fibers of trapezius, the belly of a sternocleidomastoid. Then you move down, you have the rhomboids, having trigger points all over. And if you have trigger points all over your back like that, sorry, I'm going ahead of myself, but it is okay. I want to check where I put the trigger points, malfacial trigger points. Sorry. Okay. You have malfacial trigger points, and we know when patients are having malfacial trigger points all over their upper back. Malfacial trigger point, what it does to the muscle is that it doesn't allow maximal contraction when the patient needs it. And because of that nodule-like tenderness that is within the belly of that muscle, the patient is not, the muscle is not able to perform their function optimally, especially when forces are acting against it, and the patient needs to keep an erect posture, that their head needs to be erect. Okay, so it brings about pain. There's a lot of pressure on the exoskeleton around the neck, and that's when the changes that the orthopedic surgeon saw on the X-ray started happening. Well, I discovered that while we're able to manage that, the patient feel a lot better after like 2 or 3, 4 sessions. And after the 6th session, we're able to discharge them and they go back living their life. So in essence, what I'm saying is when the patient brings cervical neck pain and they come in with their X-ray with them, I'm not saying don't look at the X-ray, but look at the patient first. Because the moment you look at X-ray and you look at the referral, you might tend to want to agree with what the orthopedic surgeon has said, that the generation of C5, C6, there is a occupied formation somewhere, there is a sclerosis of vertebral end plate, and stuff like that. Sometimes you might want to agree and believe that, okay, the condition is what the orthopedic surgeon wrote. It could be because they are managing the X-ray. But looking at that patient, if during assessment and why they are talking about their pain, none of the comments they make suggest that there is red flag in it, they can still carry out their daily activity. It doesn't disturb their sleep. What they do not like is that it's bringing discomfort to them. The best thing to do is for us to have a look at the patient. Is there any postural asymmetry? Is there any, before you even move, you should touch for tenderness around the neck, which I'm sure you're going to find. The moment you're able to find tender points around the neck, you see them wincing or grimacing, like, I feel pain there. I feel pain where you just touched. So when we're able to actually get to see all of that, then we can try to move and perform a special test of a neck compression, of a Kemp's that's contract loading, and the rest, which will actually tell us whether we have the pain in the facet joint or any other part. If the patient pain is actually radiating, how the pattern of radiation matters a lot. If the pain is not is radiating below the elbow, that means something sinister might be happening. But if it's just around the shoulder and above the elbow, it can be amenable to physiotherapy intervention. Okay, and the intervention we are going to talk about is going to involve exercise is the mainstay. That's what clinical guidelines say, with minimal over-the-counter medication. Okay, so when we have patients like that having mechanical back pain in the sense that mechanical back pain actually it has about 5 different subclasses, which we call the subgroup, or we call them subgroups, which according to authors, they have described it in a way that we're supposed to understand them. So that's the reason why we do not need to treat X-ray and treat dysfunction as physiotherapists. Okay? The moment we're able to triage a patient to a particular dysfunction that we think we have been able to ascertain through our test and measurement, then whatever intervention we carry out will relief to that patient. Because all that the patient knows is that the doctor had told me that my neck is degenerating. And when you tell somebody that his or her neck is degenerating, I think the person might not be able to sleep at the end of the day. Because if I'm not a medical practitioner and somebody tells me that my neck is degenerating, then I'm practically going to have sleepless nights. But if my neck is degenerating, then what next? What is in there for me? Okay? And from some of I don't think I have it on this slide, but I'll just let you guys know that there are other 5 identifiable subgroups of non-specific pain that we could see, which could present in form of a syndrome or in form of a dysfunction. Okay? We have dysfunction that are amenable to mechanical diagnosis and therapy, which is propagated by McKenzie. And we have treatment-based classification, which is propagated by Delito. And we have a movement system impairment, which was proposed by Sharma. And then we have the other one, we have the kinesiopathologic model, which is propagated by O'Sullivan and the other people. No, it's not on the slide. It's not on the slide. Don't move away. I'll tell you when to move. Okay. Then we have the Punjabi. Who talked about Punjabi that talked about spine instability. I talked about the concept of a spine instability. And if I walk into your clinic and you tell me that my spine is unstable, then I'm going to have a sleepless night too. So when the patients are telling us about whatever they are feeling and how they describe their pain, whatever they have said about their pain is how their pain. We should make sure we don't help them to escalate the condition. Whatever the patient says is the pain is what the patient says. That's subjective assessment. I will take it like that. This pain is making me feel uncomfortable. I used to close 4 o'clock for my place, but now I have to close by 2 to go and rest. That's what the patient is feeling. Don't tell your patient that from the X-ray, they are having an unstable neck or their neck is degenerating. No, it will not be fair for us to tell patients that. We should actually manage it and classify them according to that subgroup, either to a dysfunction or to a syndrome that is amenable to our intervention. Looking at the X-ray is not a bad thing, especially when we have ascertained that it's a mechanical low back. And for all that we have seen, if you look at the X-ray, and the X-ray says everything that the surgeon has said, are we not supposed to provide a physiotherapy intervention? Do they not get better after we provide a physiotherapy intervention? As all those things that we've seen on the X-ray, has it gone? It's still there, but these patients are walking around, they are better. So that should tell us something as physiotherapists that we'll never manage X-ray, we'll manage the patient. And we can subgroup them into those 5 groups that have actually told us about. If we're able to subgroup them, like for the MDT, that's a directional preference, and we will see it in low back properly. If we're able to know which direction of movement actually improves the pain. A lot better for us. We can centralize our pain and we incorporate our exercise therapy to actually strengthen, can be able to remove the myofascial pain syndromes that they have. And the patient will, they always feel better. They always feel better. And most of them never come back again. Or you might not see them in 2 years before they come back. Maybe after they have done something that aggravated the pain. So in essence, what I'm saying is we should be able to actually profile our patient to the subgroup or the subtype of within those 5 classes of mechanical low back pain. Because literature says 87% of people that will come with mechanical back pain. Don't let me say low back. They call it mechanical pain, where red flags are the ruled out. So we are safe to apply intervention if we're able to diagnose properly, if we're able to apply our clinical reason to be able to triage the patient and put them in the proper profile of the subtype or the subgroup of class of mechanical back pain they belong to. Okay? Cervical pain treatment. Let me just go to treatment now. I put it as a cervical pain treatment based classification. And the goal of any cervical pain treatment, the first thing is pain control. Pain control. And that's what I up clarity. And for younger physiotherapists, I would like to tell us that we don't need to do everything at the first visit of that patient. We don't need to be an hero at the first visit of that patient. That's happened over time, and my younger colleagues have learned from it. Sometimes I allow them to make the mistake and they learn from that. I'm on a slide 8 now. Dr. Osef, slide 8? Yes, 8. I'm on slide 8 now. So the goal of cervical pain treatment, the very first thing you should do is to bring down the pain. It's pain control. Forget function, forget strengthening, forget every other thing you want to do for that patient. I know some physiotherapy clinics that what they do is just to assess the patient the very first visit and get the evidence-based diagnosis that they are looking for. Because when you get the evidence-based diagnosis, they are going to have the evidence-based intervention, which will now give you the evidence-based desired outcome. And everybody will be on the same page. Both the therapist and the patient will be on the same page, and we can have the result that we are looking for. And as physiotherapists, I think we need to actually try to be on the same page with our patients most of the time. Sometimes you know what is wrong with them. You just want to apply whatever I want to apply, and we expect them to just feel better. These people need to be talked with. They need to be talked. Even while you are planning and you are formulating your treatment procedure, they should be carried along. This is what I think is wrong with you, because I've done this and this, and they can feel it themselves. No, you're not lying. They can see that you have palpated, you have moved, and you can see where they felt the pain or where they felt the pain eventually. So they can agree with you that today we're just going to do stuff that will bring down your pain. We don't need to be a neuro on the first visit of that patient. You did one manipulation and the patient never came back. That is not good enough. We don't need to be an hero. Bring the pain down. Bring the pain down. And why do you need to bring the pain down? Is because if your VAS score is saying the patient is having 6 or 7 out of 10, and they have high disability score, you can find acute symptoms, tenderness that is unbearable, and the patient have poor tolerance for examination and assessment. All you need to do that particular best visit is to look for how to bring the pain down. Apply your modalities. Look for the most comfortable position that the patient can have pain reduction. Let's do all of that without any other thing so that we can achieve pain control. If we're able to achieve that, we should be readily assured that the patient will definitely come back. Patients have left after this visit and they never came back because pain increased. I know there's one thing that we used to say in physiotherapy that, okay, no pain, no gain. Well, I'm of different opinion right now that anybody that wants to localize to therapy clinic should just be looking for where children are crying, people are shouting, because of pain or because of what you are doing to them. I think I differ a lot now concerning that. When you are trying to bring down pain, increasing the pain and telling the patient that because you increase it, the patient will feel better afterwards, I think it's a fallacy that all of us should look at. And I would like people, senior colleagues, to comment if they are wrong about that. You cannot be doing your intervention and the patient is screaming, shouting, and we're saying we have to, there's no pain, there won't be any gain. No, I think I differ from that school of thought right now. We do not need, people should not be able to locate the physiotherapy department because they are hearing shouts of children, their adults are crying. If any adult is crying, that means the technique we are using, it is not right. And we need to look for better technique to use to achieve our aim. And people always cry and shout because they are feeling pain. So if you have looked for how down pain right from the first visit, they be able to tolerate and can achieve our aims. Do gentle ROM within pain tolerance.
Dr. Olowe, please, you need to unmute yourself well, because we can't hear you. You're currently muted from your
Oh,
end.
sorry. Okay, can you hear me now?
Yes, sir, we can hear
Can
you.
you hear me now? Oh, I'm so
Yes,
sorry
sir.
about that. Okay, so I'm talking about pain control, talking about cervical pain, TBC now, pain treatment based classification. You know, pain control is the first thing that we should do, and the primary treatment should be gentle arrowhead within the pain tolerance. Don't do any exercise that is rigorous. Educate the patient around this. If you're able to achieve centralization, if you think there is a radicular symptom, beautiful. We can do that. And you can see that the patient will feel better. And what do you do to achieve that? You do your repeated movement, you do your mechanical or manual traction. Manual traction, they said, does not have the evidence, but if you can still do it with other exercise, which you can still go ahead and use that. And secondary treatment, maybe after the first visit or two, we can use our mobilization, then we can start our strengthening and the endurance exercise program. And we can re-educate posture. Because most of the time when you have cervical pain, there must have deviation in posture because of the weight of the head and because the patient are looking for comfortable position to place their head, not to feel pain and to be able to carry out their daily activities. Then we can now, if the patient is not mobile, if the joint is not mobile, we can now go ahead and do all of that. And what the primary treatment will be cervical and thoracic manipulation, scapulothoracic mobilization, and active range of motion exercises. Then we can progress to exercise and conditioning. Okay, we can strength and we can actually incorporate endurance for the leg and the upper quarter of the back. Okay, now I'm on slide 10. I want to talk about back pain, especially non-specific low back pain. Like I already said earlier on, whatever we're talking about is mechanical low back we have ruled out a red flag. So everything we talk about here is a mechanical low back. Now we move to low back, and like I said earlier on, whatever etiology you see in cervical region, you could actually see, except that of a sacroiliac affectation in the lower back. It could occur in a certain dysfunctional pattern, which I've written here. That's slide 10. It could be an articular dysfunctional pattern, which could involve the facet joint, capsuloligamental structure. It could be a myofascial dysfunction pattern, which the dominant inception is from the muscle, the fascia, and the tendon. It could be neural dysfunction pattern, where you have the nociception coming from the nerve root and peripheral, which could present as a peripheral neuropathic pain. And it can have a central dysfunction pattern, where the central processing structure that processes pain from the spinal cord to the cortex is having problem. Patient might not having mechanical pain, but they can tell you they have the pain. And whatever the patient says is what he or she is feeling. Then we can have a sensory motor control dysfunction too. Whereas there's an impaired feedback loop. Even when you apply your intervention, there is no descending pathway. The descending pathway is malfunctioning to be able to tell the pain to stop or close the gate. And the patient is having a feeling of the pain. So we should bear this dysfunction pattern, we should bear it in mind when we're actually seeing a patient looking for etiologies of where their pain is coming from. And as you can see, most of this dysfunction pattern is around the active system, the soft tissue, not particularly about the body structure of the back, the joints, and the rest. Okay? We could have lumbar dysfunction or low back pain. An example of that is ankylosing spondylitis. That's slide 11. Ankylosing spondylitis. Well, from what I have here, it occurs in male more than in female. In my years of practice, I can't count the number of females I've seen with ankylosing spondylitis. I'm not sure I've seen like 3 or 4 over 20 years. But I've seen guys that have come down with that, quite a number of them. They are usually less than 40 years of age. And we have clinical prediction rule that actually identify these people, apart from the radiological evidence, apart from the blood biomarkers. We have CPR that says, that's clinical prediction rule that says this kind of patient will benefit from certain characteristics of exercise. Okay? If they are having stiffness that is greater than 30 minutes in the morning, if they usually wakes with the low back in the second half of the night, and if they have alternating buttock pain, we could say, even without having an X-ray, that they are having ankylosing spondylitis, okay, especially if the person is a male. So we have some identified clusters of signs and symptoms that will identify these people, and I could match them with the exercise that will be beneficial to them. Okay, let me see what I have it. All right, to talk about lumbar pain treatment-based classification, TBC, properly. You know, if you look at the subtypes of a classification I talked about initially when we were talking about a mechanical low back pain, it was 5. You have the MDT, you have the treatment-based classification you have. So for it to be evidence-based, we should manage our patients along those lines. We shouldn't just say, they are having mechanical or not specific low back pain, mechanical low back pain. Mechanical low back pain, of which classification are they at? The moment we're able to classify our patients according to those 5 subtypes, there has been clinical prediction rules that have already matched them to which exercise will be more beneficial to them, which we are going to see as we go on. The little Ito developed initial lumbar TBC, similar to cervical TBC, while Brennan Ito progressed into the 3 main categories and the other guy took it further. It is basically used to actually achieve initial screening for purpose of therapy, and the management is grouped into medical, rehab, and self-care. If a patient is supposed to have a manipulation as treatment, the primary treatment for a treatment-based classification, the signs and symptoms should be that of a recent onset of less than 16 days. If your patient is having a pain, is describing a pain that is more than 16 days, then manipulation should not be part of that. That's slide 12. If your patient is having no symptom distal to the knee, then don't even consider manipulation. Then if there is segmental hypomobility, that's reduced mobility at a particular segmental level. And if your patient is having a fear avoidance belief score in the work domain of less than 19, then if there is a hip internal rotation greater than 35 degrees in at least one of the hip, then you can consider. But if it is greater than 35, do not consider lumbar manipulation in at least one of the hip. It is about 40 degrees or 50, you should consider lumbar manipulation. And as a physiotherapist, it's not everybody, especially the younger person, that can actually do this. If you do not do it correctly, you are going to cause more damage to the patient, and they're going to go away from you worse than they come, which is not the ultimate goal of what you wanted to achieve. Then the second one is the directional preference. This is MDT. And the signs and symptoms will be preference for sitting or walking in a specific position. Then centralization with motion testing and pressure with opposite movement. The moment you are able to achieve centralization with a particular, and if you do the opposite movement, the pain paralysis, you should know that MDT, that's the Mackenzie procedure, will be better for that patient. And if there is no evidence of nerve root compression in the form of a distal weakness of the limb, then you know that your primary treatment will be repeated movement exercise in a particular direction that actually relieves pain. Then for SIJ dysfunction, there's a clinical prediction rule for SIJ too. I'm talking about this clinical prediction rule not because we are supposed to rely on them. It will not take away our clinical reasoning. It will not take over our ability to triage and our ability to make proper diagnosis. It is just something we can rely on for faster delivery of our intervention to be able to, that will give us time to see more patients within a short time. The moment you know which patient can benefit from which exercise because they have these clusters of signs and symptoms, and this one, it gives you that means you are good to go and you can see more patients as you go on. Lastly, actually propose for CPR for SIJ pain, which includes a sacral thrust, tight thrust, compression, and the distraction. If they actually elicit the type of pain the patient is complaining about, you should know that manipulation, SIJ manipulation, is actually right for that patient. Not because the doctor wrote it on the paper, but because you have been able to do all of this and they are positive. Then you can deliver your SIJ manipulation and your patient will feel better. They were stabilization of motor control exercises. When do you apply stabilization of motor control exercises for low back pain? For low back pain of a mechanical origin with an instability, we can use, that's when we should. Instability does not mean the back is giving way or the back is about to fall off. It only means that the back cannot behave normally when it's actually moving in a certain direction. Punjabi actually described that in a better way, using the neural zone theory, that when you apply small force and the back behaves in a certain way, then you can say the person is having back instability. Okay? It's not as if the back is falling off, because when you tell a patient that their back is unstable, it actually gives somebody sleepless night. You can only tell them that their muscles are not strong enough to carry out certain movements in a certain way that the back is supposed to behave. Okay? And there are some signs and symptoms in form of CPR that has been identified. If a patient is less than 40 years of age, if he can actually do SLR greater than 91 degrees on side. If there's an aberrant motion, that's aberrant motion is what we see, especially when you have a muscular dystrophy. That's tight climbing. If you ask them to get up from a flex position, you see them using their hand to climb on their thigh before they can get up. That's aberrant motion. And then there's prone instability test. If it is positive, then your primary treatment should just be core stabilization and functional movement. Straight away, you don't need to do any other thing. No manipulation, no any. It is no MDT. It is stabilization exercise or motor control exercise that will be okay for that low back pain patient at that point. Then we took it further. All of these exercises I'm talking to you about, a lot of our scholars have tried it. We have done research about it and found out they are okay. The people respond better using this clinical prediction. Initially, this clinical prediction was actually developed by X for stabilization exercises, matching the patient that will benefit if they fulfill these criteria. And it has been very successful. But we took it further by combining this stabilization exercise plus treadmill. Okay. I want to see whether this stabilization exercise could produce a better effect if we're able to identify patients, because it was said aerobic and stabilization exercise, if we're able to combine it together, we're supposed to achieve a better result. Okay. So in combining this together, it involves a lot of things that I cannot talk about here, because the patient has to be educated on how to achieve a anterior draw-in maneuver, which will serve as stabilization while they are working on treadmill. I see the guy. I'm on slide 16 now. Slide 16, Usefa. Slide 16, please. Slide 16, Dr. Usefa. I'm on slide 16. 16, yes.
Okay, sir.
All right, please. So we'll try to combine stabilization exercise. It's like having a combo of exercise. Like when you have your iproxine for people that have an ulcer. So you have it coated. This one can actually be protected from ulcer. They can take the benefits of the analgesics and they are okay. So we look for how can we have a combo of exercise that could work using those prediction rules that could work better. And we're able to see that stabilization plus treadmill exercise is something that we can do. It is implementable. It can be achieved. We have done it, and we saw that the patient actually felt better, and they've been living their life. It's something we can encourage, even without doing it on the treadmill. What treadmill gives is that it gives that inclination where more recruitment of motor units can be gotten while we are doing it on treadmill. But we can do it over the ground, and the patient can achieve a lot more using this combo of exercise for those class of patients that actually that classify as having instability. All right. Then, sorry. Okay, manipulation. When do we apply manipulation for back pain patient? There are some other signs and symptoms in the form of prediction rules too. Okay, I've said earlier, but there's no symptom distal to the knee. There's segmental hypomobility. There's no FABQ, which is less than 19 in the work domain of a via avoidance belief questionnaire. And this, our treatment procedure could be. If you're able to identify a patient that fulfills this criteria during your treatment, yeah, it's number manipulation. But not everybody that can do this. We have to actually have further training, having a first degree or whatever cannot be able. We need certification to be able to do manipulation, and we must be able to do it regularly. Okay? The summary of common physical exam maneuvers for low back pain. All right. For physical examination maneuvers for low back pain. Okay, this is the examination now. When your patient, we should use gates to identify potential problems when a patient is walking. Most of the time in the hospital, we are lucky, you have the folder, you have the referral paper there. You could see that, okay, the surgeon has referred the patient for low back pain. But if you are working in your private clinic, you might not have that opportunity. But see your patient walking, even while they are holding that paper in their hand, you can be able to guess that this is what is wrong with that person. Using gates, I can tell you specifically that I've managed patients using gates in this era of telemedicine. I only ask them to do a video of themselves walking. They should walk, you look at the lateral posture, then they should walk forward and you see them walking, and they should walk while somebody is making their video from the back. You can see the deviations while they walk, and you can actually have an idea of what could be wrong before you listen to them while they are talking on phone. And I've used that, to manage patients. I prescribe the exercise, I get videos for them, and they've gotten better. So in this era of telemedicine and the rest, working in primary health care and the rest, we need to know how to use gate deviations to identify common problems in the lower. We need to do that. When the patient is talking of doing forward leaning, that might suggest neurogenic or intermittent claudication. If the patient is having his hand to waist lateral bending, that might suggest myopathy. And his patient is having a contralateral bending while they do the video, which is such that might be a sign of perilateral gait or L5 radiculopathy. If there is lateral side walking, that might be a canal stenosis. And if the patient is walking wide base with a wide base of support, that's what we call myelopathy gait. And we should suggest something more serious. And if the patient is doing toe walking, we suggest something more serious. So using telemedicine, we could use all of this. And physically, we could still use all of this. Even before they see that, you can tell them to take a walk without any support. And you can, if you have this knowledge then, you can be able to know why they lay down on the bed. You can actually go right there and see. Just make your movement and it will reproduce the pain. And the patient will build more confidence in you. The other side of this slide is talking about other tests and sensors that we can use to actually confirm our suspicion. Okay? We can use our neurological sensation of L5 along the extensus analysis number. We can use our reflexes. We can use chondral loading, which is chem test. We can do for segmental tenderness and trigger points. And we can use Faber Jasmine test to isolate our SIG. And we can use our straight leg release, of course, to isolate radicalites. It is more than this. Everything I've said here is just like a summary, like I put it. It is far, far, far more than this. Colleagues, we need to read more. We need to have more focus on the area we need to pay attention to. And there's no one assessment that fits all. And there's no one treatment intervention that fits mechanical low back pain. That's why we need to pay attention to those subtypes so that we can have a clear pathway for treatment option. Okay, the goals in managing upper and low back pain is number one is pain should be under control. Control acute pain. Control chronic pain. It is pain control. If you control the pain, that means the patient will cooperate more to do your exercise. Let's control pain. Then let's gradually introduce our exercises. If you have 5 exercises in our booklet that the patient should do, we can introduce them one after the other so that we can see how the pain behaves each time we introduce exercise. Don't let us reintroduce clusters of exercise at the same time so that we'll be able to isolate which exercise is more beneficial to the other. But if we're able to triage very well and we're able to isolate them into those subtypes, we are going to have good outcome at the end of the day because we can match the patient with the subtype of mechanical low back pain, which can match the exercise using those clinical predictions. And our goal is to protect our patient from further injury while encouraging progressive exercise. If our goal is to get the patient to do isokinetic exercise using 10 kids, we should start with 2 kids and see how the pain will behave before we keep loading our patient. And we should encourage central basing motivation, relaxation, and positive thinking. This is CBT, and that is the hint in pain neuroscience, pain management. You know, most of our modalities that we use in physiotherapy, we use it to actually modulate pain. Our exercise is the main one that actually affects the descending path. Most other modalities like TENS, they only affect the afferent pathway, that's the ascending pathway. That's why you see people feel better immediately after infrared, but by the time they go and come back, they just want to come and experience euphoria again. No, exercise does not work the same way. Our exercises actually affect the central pathway, which is the descending pathway that closes the gate completely, even if not completely, to a larger extent. Modalities only affect the ascending pathway. You have that in mind so that when we are doing that, we're just trying to minimize the pain, make the patient feel better in a short while. And we should look for how to introduce our exercises progressively as we go on. And we shouldn't forget, we shouldn't tell the patient not to take their medication completely just because we want to become a hero. No, we should allow them to take their medication. But if they feel better and they skip the medication and they still feel better, then you can leave the decision for them to take. Don't, as physiotherapy, I don't think you need to tell them to stop taking their medication completely. Right. We have some pain control theory here. I don't want to bother hospitals. I've told us that the gate control system that affects the pathway, the ascending pathway, is proposed by Merzack and Wall. But there's a central biasing theory, and that's endogenous opiate theory, which actually involves the central pathway, the descending pathway. And that is the part that our exercises affect most of the time. And when we do those exercises, those neurotransmitters was be sent down. Those we have yes, those enkephalin, serotonin, they will be sent down. And it's only exercise, only our exercises that actually does that. That actually activates this descending pathway for the gates to be closed to a certain extent. So exercise is the mainstay. But before we do the exercises, let's control pain. And that is the message that I have for us. I don't want to bother us. Yes, pain regulation. I'm on 22 now. 22 slide, please. I'm actually looking at my own computer, please. I'm on slide 22. Pain regulation using exercise along descending pathway, which will naturally elicit exercise-induced hypoalgesia, EIH. This is where our magic is. Exercise is our magic, and that's what we use. And I've listed most of these exercises that we can actually use to achieve this hypoalgesia. And the pathway that is followed is in the picture. And how it does that is a very simple thing. From the cortex down to the gate in the dorsal horn of the spinal cord that closes the gate of pain completely in that patient. We have graded exercise, we have co-exercise. Co-exercise can be done using biofeedback with a real-time ultrasound. Our scholars have done that and they found that it's good and it's far better. Then we have aerobic exercise. You can have combined core and aerobic. You can use a manipulation if you do that scientific prediction because it has to be evidence-based, okay? And that is where we are better. If you are using manipulation, no doctor will recommend that you should manipulate a patient. Only say the patient is having social back pain, refer for physiotherapy. Any orthopedic practice that will refer and say manipulate. No, it is your decision. Only you that can make this decision, and we should actually make use of that opportunity to shine and to project this profession in a better manner. We have manual therapy, we have alternative therapy, acupuncture and the rest, motor control exercises, and cognitive behavioral therapy, CBT. The cognitive behavioral therapy is an holistic way to actually manage pain, not only back pain, pain neuroscience. That means we are looking at the patient holistically. We are educating them on how this pain pathway works. We're educating them on why they feel the way they feel. And we have used this in practice, both private and hospital-based practice, and it has worked completely. It has worked. People come to hospital not because they feel pain, but they just wanted to leave their house. People come to hospital because they don't have an attention that is needed at home. And they know that when they get to your hospital, you are going to provide the attention they need, even though they are paid for it. You are going to listen, they are going to talk to you, you are going to listen to them, you are going to do certain things that even though the physiological pain might not be there, but they get out of your clinic feeling better. All in all, we should actually encourage multiple convergent therapy, cognitive behavioral therapy, CBT, with other forms of therapy that can be beneficial for our back pain patient. In summary, we should be vigilant for serious causes of low back pain, such as malignancy, infection, and fracture. It's a minute percentage, but we shouldn't allow it to slip through our hand without arresting it and sending it back to where it should be sent to. We should evaluate neurologic symptoms and other red flags Combination of multifarial symptoms, they are actually useful for diagnosis. Clusters of red flags are the ones that are useful for diagnosis. One or two red flags is not actually useful. That doesn't mean the patient will not benefit from physiotherapy care. Understanding benefits and of physical exam maneuvers is good for physiotherapy. And we should avoid overutilization of imaging, which I don't do. Most of us do not do. I can't remember last time I sent somebody for an X-ray. Diagnosis may need modification over longitudinal course of care. If you are going to keep that patient, if you have been seeing your patient for a longer than necessary time, though we didn't talk about time lag. If I have a back pain patient that comes like this, how long do you think I can see the patient before it gets better? No, we cannot say that here because treatment is individualized. People don't feel pain the same way. There are other factors that affect pain perception and the interpretation at the same time. All right. So, but if the patient has been coming to your clinic for a longer time, then diagnosis need modification. Then you have to reassess. You have to try out the patient to fit into those 5 classes of subtype of mechanical low back and see which one. Maybe whatever you have classified him or her initially was not really beneficial. The summary of our modulation procedure is that pain is not just a simple relay. It is actively regulated. That's I'm on 24 now. I'm on 23, sorry, the last slide. Talking about summary now. Pain is not just a simple relay, it's actively regulated. That means whatever pain the patient has brought to you, if it's a mechanical kind of pain, it can actively be regulated. The ascending pathway carry the raw signal. Right now, the descending pathway and you look at it is visible modulates its intensity. Modulating ascending pathway will not bring about relief of that pain completely, but modulating your descending pathway is one that will give you a better management of that pain. Thank you for listening, colleagues. Thank you for staying here with us. Dr. Osefa. Hello, Dr. Osefa. Dr. Osefa.
Good
afternoon, Dr. Osefa.
Good afternoon, everyone.
Okay.
Thank you very much, sir, for the wonderful and very resourceful presentation, sir. We are glad we are here. We are glad we have joined this presentation. We'll have missed a lot without.
Oh, Dr. Abba.
Yes, sir. I'm here. Yes, sir. You're able to recognize my voice, sir.
Thank you. Thank
you very much. We are very happy, sir, for this presentation. We are very glad. We have really benefited from this. We have learned that pain is really multimodal, not just neuro, auto. It is all encompassing. That there are a lot of things we need to know. That a lot of caution we need to take before management and many other things that you have mentioned, which are very enormous and very resourceful. We are very glad. Thank you. Despite the challenges, you are still very determined to go on with the presentation. And I'm glad we are able to go through and listen and also view the slides. So thank you very much, sir, for your passion for profession and teaching also. Thank you very much.
Thank you.
So we're open to comments. We're open to comments, questions, and contributions.
Yes. Contribution, yes. We have our scholars there. I like our scholars.
Dr. Adamu, you have made comment earlier, but we also need to hear your comment before other questions or comments. Dr. Adamu, Dr. Ashur Hamza is here also. He has made comments last week. We also want to hear from him. We have so many other people here on board. Please, we want to hear your comments and questions.
Thank you.
Sure.
Yes, thank you very much, Dr. Aliu.
Yes, sir.
I think for me, I would say it's rather interesting. I'm just learning it's like a refresher for me for most of the things that, of course, I haven't been I
You
haven't
have
practiced. I
that's
haven't been practicing for a very long time, so these are reminders for me. So I was just, I'm glued to my computer with my tea sipping, as it's morning. So thank you so much. Thank you so much.
You're welcome,
okay.
sir.
Thank you very much, sir. So, any
And thank
comment?
you very much, sir. And thank you very much, sir, for the wonderful presentation. It's definitely very, very, interesting, and I have learned a lot. A lot, I must say. So thank you very much, sir,
Thank you
for the
so much,
wonderful
sir.
presentation. Yes, sir.
Thank you.
So thank you, Dr. Ashuru, for coming and making comments. Any other comments? As we are awaiting comments or contribution from the members, I want to state my comments, sir. I think you just talk about something which is very interesting, and I've always been in that school of thought, which you have mentioned that
Okay.
we should not feel pressure to finish our clerking and also making diagnosis and also making final decision on the management.
Yeah.
This is also what I've been advocating. We always feel pressure that when patient comes, we have to know everything. We have to be able to make definite diagnosis, and we have to also be able to
No.
treat everything day one. And that is
No.
that can be really a problem because we are going to miss out a lot of things. Like you have said, when the pain subside, it can give us a clue of other problems that we need to
Yes.
read. We need to check further in the assessments and
Yes.
to be able to
Yes.
modify the actual management that is supposed to be. Then the second thing, also, I've seen a comment of someone
That's what
there.
we should do. That's
Yes,
the right thing to do.
yes, somebody made a comment about pain that you have mentioned. I've also
Okay.
attended the courses I've done, which is PNF,
Okay.
and one of their philosophy is there should be no pain in when you are
There
managing patients
shouldn't be pain.
using PNF.
There
But
shouldn't be
we
pain.
have this
Yes.
old saying that no pain, no gain. And also I saw somebody made a comment there that
No. We
I
shouldn't.
think it's trying to translate the Hausa version that the chew I can put the chew that you use pain to eliminate pain. So I think it's good that you have I highlighted this thing this thing, sir.
No.
It shouldn't be a hallmark of physiotherapy department. Anytime somebody is passing, they should be hearing adults or children screaming and shouting. And we always think that that's when the treatment is working, or that's to show the strength
No.
or effectiveness of management. So we are glad, sir, that you have raised these things, and this is especially for younger colleagues that are coming from to note these things. Um, I've also just be able to come across a certain Hausa film that somebody is watching, and you are talking about gashi, and I say that this gashi is very painful. That that they are kind of discouraging the patient in that particular film. That person shouldn't go for that for the particular when they're saying gashi,
For
everybody will
that.
know.
That's a misconception.
We are trying to say physiotherapy, and they are saying it in that in film. So what they are trying to say actually is what they see or what they heard from people. That's what they are trying to reflect in the
Yes.
film. And the woman was saying, no, that treatment is painful. Please don't go there. She's trying to discourage him. So I'm glad that you have raised this sister, and we are glad we have had this presentation despite the challenges at the beginning. So thank you very much.
Yeah.
I'll
Thank you
open the
so
floor
much.
again once more for people to make comments so that I will not talk too much on it. So thank you. Thank you very much.
Thank you. Thank you for the contribution, Dr. Abba.
So we're waiting for members. He's here. You can type your question if you can't unmute. Maybe probably some people are in a place that is very noisy. Maybe attending some events. You can type your question or your comment or contribution, or you can unmute and talk also. I think this is a Q&A session, so we'll be able to interact and voice out our own experiences or views or maybe a question. Thank you very much.
Hello, good afternoon.
Yes, good afternoon.
Okay, my name is Umar Kabo, calling from Kano. I actually work at Federal Medical Center, Bulunkudu.
Okay, thank you.
Mine is going to be a comment, especially regarding the issue of assessment of red flags in the management of lower back pain. This is a very critical issue, especially when it comes to younger therapists. So it is always important and critical to thoroughly assess patients, especially youth with chronic, excruciating, or severe back pain. Because we have had an incident where a medical doctor used to come to our clinic and we managed him for some time. So when it's young therapists that were assessing him, and we normally have some issues that some of the senior therapists don't normally supervise interns and corpus while managing many patients. You see an intern, he will flag patient, treat the patient, and discharge the patient without any senior diagnosis to have TB of the spine. So he even went ahead to have a surgery. So in these cases,
Sorry, your voice the audio is breaking. Probably network from your side. We are not able to get the last part of the comment. Hello? Hello? Okay, I think maybe he's having some network challenge from his side. But I think what he's trying to talk about is maybe something not within the scope, but I think something relevant and important that he has mentioned, which is has to do with supervision by senior colleagues at the clinics or in the wards, supervising COP members, entry point physiotherapists, and interns also. So I think that's what he's trying to talk about. But we're not able to get the full message he's trying to deliver. Thank you very much. We have a question.
Dr. I think what the message is passing across is that supervision yes, should be done by senior colleagues. We shouldn't just leave junior colleagues to discharge patients.
Yes, sir. And I think he's right with what
even though they have the license, either provisional or professional.
Yes,
the junior physiotherapist should not be in the habit of discharging patients on their own without second opinion.
That's true, sir.
It is not weakness. It is not weakness in any way. That's just the right way things should be done.
Yes, sir. That's true, sir.
That's just the right way. Okay, somebody is asking a question about neck pain and diabetic neuropathy. The treatment pattern is the same with mechanical neck pain. What? Okay. Somebody is asking a question about neck pain in diabetic neuropathy. Okay.
Yes, sir.
Will the treatment pattern be the same with mechanical neck pain? Well, it will not be a yes or no answer because diabetic, it will not be a yes or no answer, okay? Because diabetic neuropathy in itself is already a red flag. Do you understand? If the candidate, the participant is listening, diabetic neuropathy is already a red flag. Understand? And we know what neuropathy is all about. We should have an idea of the percent of neuropathy. And if the underlying condition that is bringing up the neuropathy is diabetes, we have to check whether it is controlled or whether diabetes is controlled or not. How long is the neuropathy? If the pain doesn't have a mechanical origin, you shouldn't try to apply mechanical treatment for it. Okay? Or maybe what the person is trying to say, if a diabetic neuropathy is mimicking radiating neck pain, or there's an underlying diabetic neuropathy that presents like a radicular kind of neck pain, what do we do? In this condition, if you can try the patient, if other conditions, all things being equal, if that situation is normal, no, even if there's evidence of degeneration and the rest, if you look at other things like myofascial trigger points, weakness of the neck muscle, if there is need for cervical traction to relieve pressure from whichever nerve that is actually, from whichever plexus that is actually giving the pain. And if we can trace the pattern of the neuropathy from the plexus, then we can know where to apply our traction and to apply our treatment. But this is a medical condition that still needs medical treatment at the same time. I'm sure if this patient is treated normally and the diabetes is controlled, we might have a desired result with our treatment, coupled with our treatment within a short time. That's what I think. However, for the candidate and for the participant, I'm sure maybe this person has been managing a neck pain with an underlying diabetic neuropathy, and we're not getting results. But the person should type and let me know what exactly they are looking out for.
Thank you very much, sir, for the comment. Any more comment, please? There's also another, okay. There's also another comment. Okay, the individual has made a comment. The one that was unable to make the...
Okay, my network went up. I was talking about the need for thorough assessment, especially for constant excruciating pain. Constant excruciating pain is a red flag. And also the need to close supervision of interns. Okay, well, that's a red flag also. That's part of red flag that we're talking about. So having a thorough assessment is just the right thing to do. I think the person is on the same page with that. That's a participant. I've sent the slide for, are we supposed to have break? I've sent the slide of hip and knee to Dr. Sefa.
Okay, sir. Okay, sir. Okay, sir.
I don't know whether I was supposed to have a break or I should just go ahead.
Okay. It depends on you, sir. If you want to go on break, then we'll go on break and come back.
No, I can go ahead.
If you want to take a break, sir, we can take a break if you want. But if you want to continue, so that once and for all you are done with it and you rest.
I'm done. All right. If the participant, I can see that participants are still here, I think we can just go ahead and talk about the evidence-based assessment and the evidence-based management of pain in the appendicular skeleton. Well, we have chosen hip and knee as our focus. Okay.
Okay, sir.
Can you share? I've already sent the slide to Dr. Sefa. I've sent it to his WhatsApp.
Okay, I'm contacting him now to forward it to me so that I can share it now.
Share it. Okay.
I'm waiting for his response.
Okay.
I can share it to me directly. Let me just chat you up. You can send it to me directly.
Directly. Okay. Let me see. Can you just chat me so that I'll be sure I have your WhatsApp number?
Yes, sir. I'm doing it. I'm just going to chat.
Can you chat? Okay. Can you chat me up so that I can?
Yes, sir. I'm doing
okay.
it.
All right.
It's not close by, so let me just take over.
In the meantime, sir, maybe you can make further comments. Dr. Aisha has made further clarification on the earlier questions she made regarding what do you call it, mechanical lower back, mechanical neck pain and diabetic neuropathy. She says that it's a chronic DM poorly controlled, and the patient is currently on insulin with neck and lower back pain, not responding to treatment. His BP too
not
is poorly
responding to,
treatment.
and BP is too poorly controlled too. Well, that's then has associated comorbidity. So managing such patients, it has to like I said about a CBT. That's we need to make use of a behavioral therapy, cognitive behavioral therapy, because this presentation here is showing somebody that naturally be having other symptoms that is not related to this pain. Do you understand? So we need to actually starting mind to be able to use a neuroeducation, pain education to be able to get the best out of this patient. Somebody is on insulin already. I'm going to the peak of management of diabetes, having neck and back pain on an uncontrolled and a poorly managed blood pressure, and this diabetes is poorly controlled too. So what we need to do is to get the patient to know that this diabetes must be, the patient must be compliant with whatever treatment they have prescribed to control the DM and to control the BP. There's little, if BP is poorly controlled, there's little you can do not to aggravate these two conditions. Even your exercise could actually aggravate these two conditions without you getting any desired result. I think we need to sit this patient down, educate him on why this comorbidity could actually aggravate his painful condition, the one that is having at the neck and the low back, and why he needs to actually cooperate with this the treatment of the two. BP must be controlled, diabetes must be controlled before we can have a desired outcome. Okay, it must be controlled fully before we can have a desired outcome. I'm not saying, in this kind of patients, our modalities might not be able to achieve much here. But basic exercises, we're able to track this patient to any of the subtype of that mechanical low back that we're talking about, we might have a desired result here. Okay, but we don't even have the age of that patient. There's no age here. We don't have other demography that could tell us where actually this patient belongs. Okay, but in my own opinion, I think this patient should be sat down, get him to comply with this treatment, get the DM control and the BP control, so that at least whatever we are doing can have a desired effect. Dr. Sefa, are you back? Are you the one? Hello? Dr. Sefa, are you back? Okay.
Hello, sir. I sent a message. Okay, I can see you are
Dr.
now
Abba.
responding to the message.
Yes,
Okay.
yes.
Yes, I
I'll
can
forward it now.
see.
I'll forward it to you now.
Okay. Thank you.
Somebody was asking a question about a poorly controlled
Yes, sir. Yes, I'm listening to
BP.
the. Yes.
And we have to sit the patient down and get the patient to comply. Because if the patient is not complying with the management of those medical conditions, I'm not sure it's going to comply with a physiotherapy intervention at the same time. I've sent it.
Yes, sir. I have it here.
Okay.
Okay, I'm sharing the slide now. Hip and
Okay. Yes, I think I'll just go ahead. Yes. Appendicularis.
this is it, right?
Yes.
Okay.
Appendicularis.
Thank you very much. We are going into the next session of presentation, and as you can see, as projected on the slide, go ahead, sir. Thank you very much, sir.
Okay. Thank you, our participant, for still staying with us. We are glad that everybody is there. And we are hoping that we're going to gain one or two things from this presentation that will actually better our practice. Okay, now I'm supposed to be talking about evidence-based assessment and evidence management of pain in the appendicular skeleton using hip and knee as our focus. Okay. Well, quickly, common facts about hip pain. I'm going to start with hip pain. I want us to just have this in mind. Common facts about hip pain. Hip pain is common in adults of all ages and even children. And it prevents some certain kind of activity level. In non-elite adult soccer players, about 20%, 20% to 45 have hip pain injuries. Women, about 49%, and in men, we have about 55% of men coming down with hip pain, as in laying a complaint of hip pain. Hip pain is highly relevant because of its painful nature and because of the associated disability with obvious gait dysfunction. Everybody has to walk around. We have to look for daily bread. We have to do other things. We have to, and movement, locomotion movement is one fact or one factor that keeps us moving. We must move, and that's our mantra. Everybody must keep moving. And when anybody has hip pain, definitely you must see them in your clinic. Okay? The pain's location, wherever the pain is, or wherever the patient points to, allow your patient to point to where the pain is, if they can. Let them be able to say, this is where I'm feeling the pain. Provide a clue about its cause, so that you won't need to be racking your brain about what could have been the cause, what could have been, because you have a lot of structure around the hip that could bring about pain. So all we need to do is to allow the patient to first point to the spot. And from there, your job is made simple. Pain inside the hip or groin is often joint related. So if the patient is telling you that the pain is right inside his hip, you should know that it's actually joint related. But if the pain is on the outside and upper side of the top, it's actually from the soft tissue. Maybe the muscles, some ligament that actually crosses part of the joint. Okay. So those are just quick common facts about hip pain that we need to just bear in mind as we try to see how to manage or how to assess hip pain. I have a picture of hip anatomy here. All of us know that. I have a radiographic picture here. All of us we have been taught about hip joints in anatomy. We have talked about pathological conditions in hip pain, several of them, ranging from that could affect both children and adults at the same time. This is just like a reminder for us. Okay. The key components of evidence-based hip assessment should involve history and gait. Like I told you, in pain, in a low back pain, gait assessment is one important tool that we can use to quickly triage our patients and see the compartment where their pain belongs to. When a patient walks into your clinic, while you are observing your patient, when they are walking into your clinic, if their step is antalgic, or you see their tremor sign, and you ask about the pain location and you're able to point to that spot, and your job is made easy. And the moment you ask about aggravating and easing factors and how it impacts on their daily life, your job from there is made easy. And for your physical examination, when your patient is on the bed, while they are pointed to the side of the pain, pointing to that side of the pain, I will see why it's important as we go on to make our job easier. Okay? For your physical examination, if they are pointed to a certain part of that hip, you palpate for your tenderness. You actually palpate for tenderness over the muscles and bony landmarks. Okay? You are not just pressing all around your place, groping like we cannot see. We should look for bony landmarks to palpate your PSIS, your greater trochanter, the iliac crest. You should palpate intentionally, not just groping around. Okay? And we should look, after we have done that, if we're able to find tenderness over, we can actually move if it's within the tolerant level of the patient. We can actually move to look for limitation in range of motion. Okay? Then we can go ahead and carry out a special test for intra-articular pathology. We have a paper, we have a Paddy, we have Scott test, we have a Thomas test. I have it here. I don't want to start reading that. Test for whichever tissue or whichever structure that we think it's affected. Okay, so I'm on slide 5 now. The common reported outcome measures are the one I talked about here. We have hip dysfunction and osteoarthritis outcome score. We have Japanese. As we have Japanese too, we now have Ibadan. We have Ibadan, knee and hip osteoarthritis outcome measure. Some days, very soon, I'm sure we're going to have Kano. We're going to have Kano osteoarthritis, hip and knee osteoarthritis, or some other measures that will be peculiar to Kano. Maybe we have already and I didn't get to see it. Okay. Then moving away from what's the relative importance of a common reported outcome measure? It's just for clarity and it's just to be able to quantify how the treatment has benefited the patient and basically for research purpose most of the time. Most of the time in our clinic, we don't take advantage of these measures, which makes research difficult sometimes. But it's something that we can actually incorporate at a clinic level, both in all the hospitals that we can, when researches are going to be conducted, either retrospectively or a prospective observational study, we can get to see all of this in our case folder so that we don't need to start looking for the patient again to take our measures. Okay. Then the evidence-based approach to hip pain evaluation. Well, what I'm able to put down here is that, and when I said you should allow the patient to point to the site where the pain is, hip pain is often compartmentalized, one of 3 locations: the anterior, the lateral, and the posterior parts. Okay, I'm on slide 6 now. I'm on slide 6. Evidence-based approach to hip pain evaluation. If I'd allow your patient to point to the part where the pain is, if it's located anteriorly, we already have the common causes. If it's located laterally, we already have the common causes. And if it's located posteriorly, we already have the common causes. It makes the job a lot easier. When the patient is pointing anteriorly, that the pain is located anteriorly, you should be thinking of intra-articular hip pain. And the common causes will involve a hip flexor strain, tears, and avulsion fracture. It can be a referred pain from intra-abdominal problems from appendicitis, hernia of bladder, or ovarian cyst. And the differential intra-articular causes can be, a femoral acetabular impingement syndrome, labral tears, vascular necrosis, osteoarthritis, hip fracture, or femoral neck fracture. Okay? So when a patient points to an anterior part of the hip, our job is easy if we have all of this in mind. Okay? And if the patient is pointing laterally, see, the lateral part, when we say we should palpate the bony landmarks, you have the greater trochanter located laterally. So the lateral hip pain could be said to be a greater trochanter pain syndrome, or you can have a trochanteric bursitis there. Okay, and the common causes might be gluteus medius tendinopathy because they have their insertion there, or tears, iliotibial band friction, and external sapping hip because they actually overlay greater trochanter. And you can have a gluteus medial tendon here. But those are the structures that are around that place. Then if the patient is pointing posteriorly, though they say this one can be difficult to diagnose, but it is the difference that could involve a referred pain from the intrapelvic or gynecological issue, pelvic inflammatory diseases. They might have the deep gluteal pain syndrome, which we usually refer to as piriformis syndrome. You can have an ischiofemoral impingement. All of them are located posteriorly. And you can have hamstring injuries, proximal hamstring tendinopathy or tear. And you can have the major culprit, most of the time, sacroiliac joint pathology and associated lumbar spine pain. Okay? So if all of this, that's a picture we can have in our head anytime a patient is bringing a referral of hip pain to us in our clinic. Allow them to point to where the pain is. And from there on, the job is made a lot easier. Common tool for assessing hip and knee pain assessment, we have talked about it, and we can look at the slides later. Then you should look for, then we have some performance-based physical function tests, which is good for research and is good for clinical practice too. But this one will be able to tell the patient what they cannot do, what they can do now, and to be able to appreciate whatever intervention that we have actually rendered to them. Okay? Then hands-on assessment we have said about or talked about is palpation and observation is actually good. Gait is one thing that will never fail you. I can assure you that. Observe gait closely, and your assessment and the other things will be made a lot easier. Assessment of knee pain. Knee pain is being said to affect individuals across all ages and can be caused by a variety of conditions, ranging from acute trauma to complex long-term conditions. Okay. After back pain, knee pain is the most common site of musculoskeletal complaint, and the reason is not far-fetched because it carries about 75% of our body weight in standing. And if anything happens to our knee while it's rooted on the floor, the knee bears more, it bears the pain more, it bears the impact more than ankle and the hip. Okay? So because some of us have other deformities while growing up and the rest, the knee suffers a lot more than the hip because the line of gravity passes through that place and forces are resolved around the knee. So it has to be, the integrity of our knee must be 100% at all times, okay, for it to actually provide a sufficient function. And the common symptoms of a muscular condition include pain, stiffness, swelling, and variety of dysfunction. I got it, how to assess knee without stress. We can use the Socrates assessment tool, especially when we're in the clinic. If we are doing research, it's a lot easier because it is research. But when we have loads of patients to see, we really need to move forward quickly so that we don't keep people waiting. We can use Socrates assessment tool. Site, where is the pain? Let the patient point to where the pain is. The way the patient is able to point to where the pain is, then the rest of the job is easy. You already, from your knowledge of anatomy and the rest, you know which and what structure will be involved. And you can see the pattern of the joint involvement, which we call dysfunction or dysfunction and the syndrome. Okay? And we can check for the onset. Socrates is the mnemonic, and it has been explained here. You can ask for the onset. Was it sudden or gradual, acute or chronic? And we know all of that, what that means, using our knowledge of a red flag and the rest. If it is sudden, it's unexplainable, there is rapid swelling and we should suspect something there. Then the character of the pain, is it dull ache, is it sharp, is it stabbing, is it worse, is it preventing somebody to sleep, does it radiate below, does it have associated symptoms like increased temperature, inflammation, locking or giving way? Nothing has been able to relieve the swelling, nothing has really been able to relieve the warmth. We should look at all of that. And we should look at the time duration the pain is present at rest and when he wakes up from sleep. And we should look at the factors that relieves it and the factors that exacerbate it. Okay, that's for Socrates. And this one will give us a stressless way to clearly evaluate, clearly assess our need and be able to isolate the pathology, the structural pathology that involve this and a picture of the anatomy of the knee, which all of us know about. We have specific clinical tests that we can do. But when we are doing a clinical test, what we usually say that I was taught, that I've learned, and I've taught other people is the very first thing is first for you to look at that knee, any swelling, before you even touch. Look at the orientation. Look at whether there's deformity. Look at every other thing. Look at, is the skin changing color? Look at it. Is it shiny? Because for patients that have septic arthritis, you can get a slap for trying to move that leg. Let's look at all of that. And if patient slaps you, you might be hungry and, well, no, it's not their fault sometimes. But it's when having septic arthritis that's not been done, that filtered through the clinical pathway and gets you, then you shouldn't allow you to sleep through again. Okay? Then, inspection, we should observe gait, you observe for swelling, scars, bruises, muscle wasting before you even start moving. Then we should practice. If there's pain tolerance and the patient will not be overly reactive, we can check a range of motion to check for efficient tests. We have several tests that involve ligaments here, which all of us know. We should do all of that. We shouldn't say we are suspecting that it's anterior cruciate and we forget to do posterior cruciate. We should do all of the tests and document that they are either they are negative or they are positive. Okay, then these are other tests that we can do here. Then if you suspect anything, we can actually refer the patient back to the physician, like talked about a red flag. But if you think what you have in front of you as a primary care physiotherapist, you can send your patient for blood tests to actually check for biomarkers, especially if you're having the pain in multiple joints, not only knee alone. You have it in the hip, patient is complaining of the toes and hand there. You can send the patient for a blood work. And what you're supposed to look for has been written here: full blood count, the purpose of it, white cell count. This is suggestion of infection. Elevation of all these suggests something. Okay, and we can do that. I think we can still do that as physiotherapists, especially find yourself in primary care, not within a large setting of a multidisciplinary team. All right. Then also synovial fluid microscopy and culture can be done to rule out all of these. And when you're able to do all of these, I think the job is to be able to make the other job of the physician is attach and write your referral to whoever you think will be more appropriate to see the patient. Sorry, please. All right. Evidence-based management of hip and knee. I have to put it together because both hip and knee have common features. They behave the same way. They are weight-bearing joints, which when pain occurs there'll be a greater level of discomfort. Okay, I'm on 17 now, Dr. Haba. I'm on slide 17. Evidence-based management of hip and knee pain. You know, we have best research evidence that has been talked about over time. And we have a clinical opinion, expertise opinion, and sometimes we have that's 17, slide 17. We have patient values and preferences. Okay, what you think is okay for the patient, what the best research evidence has suggested, and what your clinical expertise and the experience have gained over time might not be what the patient prefer. Okay, that means for evidence-based management to be holistic, the patient must be involved in it. Okay, but that's when we can get the buy-in. 17, please. 17. Slide 17. Okay, that's when we can get the buy-in, and that's when it can become an evidence-based management. That means we have applied what the clinical guidelines are saying. We have applied our clinical expertise and experience over time, and we have incorporated the patient values and preferences. That's when it can become evidence-based. I have quality guidelines for hip and knee exercise constantly recommend clinicians implement exercise, education, and weight management, alongside consideration of non-steroidal anti-inflammatory drugs. And at the end of the day, maybe the pain is not resolved, intra-articular corticosteroid injection, which our colleagues in UK that are serving as best contact actually participating in right now, especially around the shoulder. Okay, but the basic guideline from the higher studies, systematic reviews, and the meta-analysis is exercise. Exercise is the mainstay. Education, pain education, lifestyle modification education, weight management, because weight is actually one of the factors that actually break, apart from traumatic hip or knee pain, weight contributed to the degenerative changes that we see and brings about hip and knee pain. Okay? Evidence-based conservative management for hip and knee pain focuses on exercise, and that's where we are involved. Strength aerobic exercises, the use of hydrotherapy. You know, basically most of us with therapists are maybe because of our training and because lack of facility, we are basically used to land exercises more than hydrotherapy exercises. But I can as well tell us that hydrotherapy will be more beneficial, especially in a very painful knee or very painful when the patient does not need to bear weight. We can take advantage of mechanical properties of water like a buoyancy to get our patient to do the exercises that we could do on land without any hazard, and the patient will benefit. And there's always a chance for progression, even within the hydrotherapy. Weight management, education, and physical modalities like electrotherapy can be used to bring down pain. That's for pain control, not for any other thing, for pain control in the management of people with hip and knee pain. For it to be evidence-based, all of this has to come into play. Okay? For evidence-based physiotherapy treatment, we can use impairment-based function training. That's gait training and balance training. Well, it was a grade C recommendation. Balance exercise was conditionally recommended. Individual exercise prescription based on individual daily life participation is a grade C recommendation. Other exercises are manual therapy recommended too. The other modalities like ultrasound, acupuncture, or thermal intervention, TENS is actually recommended against. Okay, so some of us still use TENS to manage it, but if we check it properly, what is TENS doing here? If you are using the EMS component, we can be able to write that, we can be able to justify it, or can be able to explain it. But using TENS, but you tell me that you have used TENS and the patient got better, but you didn't use TENS alone. You must have used other exercise modality. You use TENS to control the pain, just temporary relief of pain, so that the patient can cooperate with you to do your exercises. It's okay. So I won't spread anybody using that if that works for you. But in the evidence for evidence therapy, it is actually recommended against. Okay. Now I put some predictors of hip and knee injury recovery here. While we're trying to manage these patients with hip and knee, we shouldn't be oblivious to the fact that all of them will not recover at the same time, depending on this factor: age and activity level before the injury. If patient A, his activity level was better than, and the injury is far less than patient B, how you expect that, and is younger than B, then the patient will naturally come to recover better in a no time or less time than patient B. Talk about severity, then location, the structures that are involved, and whether patient have had previous surgery or not. Somebody is having both ACL and PCL rupture. You can't compare that with somebody that is having just a meniscus tear with just partial tear of anterior cruciate ligament. Rate of recovery will be different. But patients that come to clinic and say, I've been coming from this, I've been coming before this patient. Now this patient is walking and I'm still here. My range of motion is not full. I still experience occasional swelling. But we should be able to explain. And that's when we're talking about a back pain. We should communicate, we should talk to these people. We should talk to these and their conditions are not the same. They talk among themselves when they sit down there waiting for their treatment. And from that, some patients can become anxious, started having signs of psychological stuff, and the treatment procedure might not go as intended. Okay? So predictors of hip and knee injury, we should take into account achieve on time. I'm talking about exercise, evidence-based assessment, evidence-based intervention, evidence-based outcome. I have everything in here. We can actually quantify our intervention by using those questionnaires that I've listed, so that we can be able to have something on ground to justify our intervention most of the time. Okay, if I'm supposed to start taking each condition one after the other, I'm sure that's a course that's been taught for a whole semester. But these are just basic things that puts in here. If we are able to isolate the pain or the structure that is then our job, it's a lot easier. Dr. Abba, I think whatever any question anybody has, we'll be able to talk about it. If there's a clinical scenario that they want us to talk about, then we'll talk about it as the floor will be open. Thank you all participants for listening. Thank you for giving me this opportunity to talk to us. I'm really grateful, and I promise to do better next time. Thank you so much. Dr. Abba.
Thank you very much for the presentation, sir. Dr. Abba is indisposed. Currently, I'm deputizing for him. It's Huzaifa Imam again. Thank you for this
Okay.
stimulating and enlightening presentation. And we are glad that we managed to get you to do this despite your busy schedule. Thank you very much, sir. And
Thank
I'd
you.
like to leave the floor open for questions and comments in the next few minutes so that we can go on a short break before Professor Badaru comes online. So questions and comments, please. The floor is now open. You can send your questions to the comment section, or you can raise your hand, your virtual hand, and make your comments or contributions, please. Questions, comments, and contributions, ladies and gentlemen. We just finished listening to the presentation by Dr. Olori on the etiology, evidence-based assessment, and management of pain in the appendicular skeleton. So questions and comments on this topic are welcome. Well, it appears that we do not currently have any questions or comments, sir. So on that note, I will ask us all to go on a short break for 15 minutes. Let's say we'll come back by 1:35, and we'll continue with the presentation proper with the presentation on oncologic pain by Professor Umar Muhammad Badaru of Bayero University, Kano. Thank you very much, Dr. Olawi, for your presentation, sir. And,
Thank you so much.
We're going on break now.
Thanks, everybody. Okay, now. Thank you. All right.
Allodynia, pain perception response to those non-painful stimulus. Therefore, you touch somebody, you massage that individual, he's supposed to feel okay, but he feels that, guy, this your touch is painful. Therefore, there is sensitization in cancer pain. Somebody who says, I'm feeling pain when you touch me, you know that that guy is having sensitization. And then there are procedures for approach in the management of sensitization. Then we have mixed pain. Yes, usually individuals with cancer, most especially those with some metastases, actually used to experience mixed pain. Pain as a result of what do you call it? Pain emanating from tissues that are non-neural, and another pain emanating from neural tissue. Therefore, they now have a combination of nociceptive and what do you call it? Neuropathic pain. It is characterized by a combination of nociceptive and neuropathic pain, symptoms of fluctuating or breakthrough pain patterns. Okay, please, there is, and this particular breakthrough pain that is common in individuals with cancer. What is this breakthrough pain? There is a pain, it's just like we used to say exacerbation and remission. Therefore, whenever you have an exacerbation of pain, we call it breakthrough pain. Let me give you an example. A patient is having pain as a result of cancer, and that pain has been under control by either non-steroidal anti-inflammatory drugs or opioid analgesics. The opioid analgesics have worked. The patient is no more under any pain. Suddenly, the patient will now have sharp pain that will last some 2-3 days, so debilitating. Then they call it what? Breakthrough pain. That is a fluctuation, or what do you call it, an exaggeration of pain in an otherwise stable and controlled pain episode. That we call it breakthrough pain. It's a characteristic of mixed pain. Mixed pain can have no, what do you call it, nociceptive pain the patient can handle. One day he will just have an increase in pain. There is combination of what do you call it, nociceptive and neuropathic pain. It is assessed using comprehensive multidimensional assessment. Therefore, where we have mixed pain, therefore the best is to use brief pain inventory or McGill questionnaire. Therefore, they can have combination of symptoms of both what do you call it? They can assess combination of symptoms of both nociceptive and neuropathic pain. Treatment requires combination treatment, opioid and adjuvant therapy. We have flexible opioid rotation, psychosocial therapy, and we can also have physiotherapy management in the, what do you call it, management of mixed pain. Then now classification of what do you call it, of pain based on mechanism. Here, the classification of cancer pain based on the mechanism, we have, it's like, what is the cause of this pain? What is the cause of this pain? What is the cause of this pain? That is it. Therefore, the classification, we have what we call chemotherapy-induced chronic peripheral neuropathic pain, meaning that it is caused by chemotherapy. It is drug-induced. Radiation-induced chronic neuropathic pain, meaning that this one is caused by the radiation. Then we have chronic post-operative pain. We have this pain caused by what do you call it, cancer-related surgery. These ones are classification, what do you call it, based. Therefore, we have pain as a result of chemotherapy, pain as a result of radiation, pain as a result of the surgery that is being conducted. Therefore, this is what we call classification-based mechanism, based on mechanism. Then we have medical management of oncologic pain. Actually, this presentation is not based on medical management. We just highlighted them. We have, it requires prescription of NSAIDs. Therefore, for somebody who wants to know what do you call it, more about medical management, most especially drug management of cancer, you should read about WHO ladder of what do you call it, our treatment ladder, analgesic treatment ladder. Therefore, when you check WHO analgesic treatment ladder, that is what the doctors use for the prescription of drugs for management of oncologic pain. We have NSAIDs and opioid analgesics. Therefore, usually the NSAIDs are prescribed for musculoskeletal pain that is not related to cancer. It is either related to disuse or any musculoskeletal related injury or fall or anything. NSAIDs can take care of it. But anything that has to do with cancer is usually amenable to only opiate analgesics. And then remember one thing with opiate analgesics, they can induce dependency. The patient will have the pain coming back when the drug is withdrawn. Then we have surgery involve removal of tumor or surrounding tissue. Therefore, remember we talk about phantom limb pain. When individual is having phantom limb pain, is as a result of the organ, when an organ is removed due to, most especially limb, either upper or lower limb, due to what do you call it, a tumor. He can have phantom limb pain. Surgery can involve removal of some, even part of what do you call it, our brain that has been involved, some part of our intestines, some part of our, what do you call it, muscles. Therefore, the removal of any tumor and surrounding tissues that are likely to be affected by the tumor is done through surgery. The radiotherapy is used to destroy the remaining cancer cells after surgery, meaning that in essence, the first choice of treatment is to see if surgery can remove the cancerous part. Then after the surgery, the remaining part of what do you call it, the remaining cells that are very close to the tumor cells can undergo radiotherapy with ionizing radiation. The next is chemotherapy. This is, we use cytotoxic drug to kill rapidly dividing cancer cells by damaging their DNA. But remember, these cytotoxic drugs can also damage normal tissues. They say cytotoxics can also cause damage and death of rapidly dividing healthy cells, such as those found in hair follicles, digestive tract, bone marrow, and peripheral nerve endings. Therefore, chemotherapy can also cause damage to, what do you call it, rapidly dividing normal cells. Therefore, it can cause peripheral neuropathy. It can also damage some normal, tissues of the body. Okay, physiotherapy management approaches to oncologic pain. A systematic review reported that massage therapy and progressive muscle relaxation had significantly reduces cancer pain. Therefore, generally in our discussion, you see a lot of systematic reviews being discussed, and and RCTs, because we believe they are stronger in defining causation. Therefore, the first one is a systematic review by Lopez Jr. et al. 2020. They report that massage therapy and progressive muscle relaxation significantly reduces cancer pain. Therefore, for individuals with cancer pain that are on opiate analgesics and they are referred for physiotherapy, they can also benefit from progressive muscle relaxation and massage therapy. Another systematic review found that music and massage therapies has the most beneficial benefit on range of outcome parameters, including cancer pain and quality of life. Meaning that for individuals that are used to music, bringing somebody who is an expert in music therapy to perform, and also physiotherapists to perform massage on the patient, can relieve pain. The Society for Integrative Oncology guideline provided evidence-based recommendation that acupuncture or reflexology or acupressure can be used for general cancer pain and musculoskeletal pain. Therefore, this particular body says that they have okayed that individuals that have cancer-related pain and musculoskeletal pain can benefit immensely from acupuncture or acupressure. Therefore, for those of us that have training in acupuncture and acupressure, this is a variable tool for management of cancer pain. They said both cancer-related pain and musculoskeletal-related pain can benefit from acupuncture. Okay, the issue of sensitization, somebody having increase in pain in a situation where there is little or no pain, and then we have another process where somebody touches you, which does not supposed to cause pain, but you feel pain. That is the allodynia. Therefore, when a patient is having sensitization, either central or peripheral, the studies have shown that stents addresses the central component of cancer pain and is very useful therapeutic adjunct in patients with central sensitization. We have a hypersensitive skin. Remember, we talked about desensitization despite the fact that there is hypersensitization in in chronic neuropathic pain, there is also desensitization. They said if somebody is having a hypersensitive skin, it can be treated with sensory re-education method. For us, with therapy, we can have different sensory re-education method, even your bruising, tactile stimulation, brushing, altogether, even massage can give some sensitization. Then we have hypersensitive skin. They said if somebody is having hypersensitive skin, that is more of peripheral sensitization. They said cold therapy, that is cryotherapy, can desensitize the skin, decrease nerve conduction velocity. What they are saying is cold therapy can desensitize the skin, cold therapy can decrease nerve conduction velocity, and they can desensitize the nerve engines. It is also believed that massage and compression garment can be used to desensitize the skin. What they are saying is when the compression garment is applied and followed by massage, and Dry et al. Found that it can desensitize the skin of the patient. Okay, we have local inflammation and nociceptive pain. Where there is local inflammation, patients with cancer are prone to having local inflammation, and they are prone to having nociceptive pain due to local inflammation. Another research found that massage therapy improves local circulation and gently stimulates the new, free nerve engines. Then another research found that low-level laser therapy reduces pain and improves healing of radiation-induced mucositis after 6 weeks of therapy in the head and neck cancer patient. Therefore, what is happening here is it is found that individuals with head and neck cancer that undergo radiation therapy, usually they experience inflammation of the mucous membranes. Therefore, another research found that when low-level laser therapy is used, it reduces the pain that follows mucositis due to radiation therapy, and it also frees what do you call it, head and neck pain in patients with head and neck cancer. Then the last aspect of physiotherapy management approaches to cancer pain is aerobic and resistance exercise. This is a very recent study conducted by Dustin et al. 2024. They conducted a systematic review and meta-analysis. They reported that aerobic and resistance exercises are tolerable and effective adjunct therapies to reduce cancer-related pain, while also improving physical function, fatigue, and mood. What they believe here is that when individuals are undergoing cancer treatment, the physiotherapist can also prescribe aerobic and resistance exercise. What they found in their systematic review is that aerobic and resistance exercise are adjunct to other therapies that help to reduce pain. They also reduce the pain in this particular patient, and they also improve physical function, fatigue level, and mood. That is for cancer-related pain and management. The next is physiotherapy in palliative care. Actually, what we did the other time is still part of the palliative care, but when we say cancer pain can occur even in somebody who is not terminally ill. But when we talk about palliative care, we are talking about somebody who is terminally ill. He is receiving the last, what do you call it, doses of treatment at the end of life. WHO defines palliative care as an approach to care that supports physical, emotional, social, and spiritual needs of a person with life-limiting conditions. What WHO is saying is that when you provide care that supports the physical, meaning that supports somebody's ability to function, emotional, that supports the psychological feeling of the patient, social, that helps somebody to interact with other people, and spiritual needs, you give care that brings somebody to his God. Probably you preach to him, you say so many things about reward of somebody who is sick. God is going to reward him. There you are giving palliative care. They say palliative care focuses on improving well-being and quality of life of people suffering from life-threatening illness. They said in physiotherapy perspective, that is in our perspective, palliative care should not be limited to end stage of life. What we mean is that for individuals that have cancer, for us, if we have palliative care unit in physiotherapy, the patient, even before he reaches the end stage, we should be involved. We should be able to maintain his level of fitness. We should be able to maintain his independence level. We should be able to reduce his pain level even before he reaches the end stage of his life. Then they said palliative approach to care can begin much earlier and can be applied not only to conditions usually considered for palliation. Usually when we say palliative care, we are looking for people with end-stage cancer, but also to chronic debilitating disorder. Example, neuromuscular disorders, cardiothoracic disorders, HIV and AIDS, dementia, chronic liver disease, end-stage renal disease, neurodegenerative diseases, all diseases that are very debilitating and keep patient bedridden. They should be considered palliative as far as physiotherapy is concerned, not only the end-stage cancer patient. They said, what is the aim of physiotherapy in palliative care? Physiotherapy in palliative care aims to enhance physical and functional well-being of patients with terminal illnesses such as cancer. Such patients suffer from chronic pain, mobility limitations, limb edema, fatigue, depression, and eventual diminished health-related quality of life. Here, this particular statement is telling us about the major problems faced by individuals that have terminal illness. They are still suffering from the pain we discussed in the first part of this lecture. They are suffering from mobility limitation. Most of them cannot move. Those that move, they move with difficulty. They are suffering from lymphedema, swelling as a result of as a result of dysfunction of the lymph drainage. they suffer from fatigue, and fatigue is being exacerbated by weakness. They suffer from depression because of loss of hope and so many things. Therefore, these ones are the major problems faced by what do you call it? Patients with cancer at the terminal level. Therefore, physiotherapy is aimed at alleviating all these sufferings of the patient. Physiotherapists may be involved in the optimization of recovery of strength and movement and management of breathlessness. Therefore, when the patient's strength is being compromised, physiotherapy can be used to strengthen what do you call it, the musculoskeletal system, improve the movement ability of the patient, and management any form of dyspnea or breathlessness the patient is having. Therefore, the common problems for patients who have cancer in palliative phase. Therefore, the palliative phase of the cancer in patients is the last stage where the patient will just be bedridden. He cannot do much. We are just trying to maintain life. Therefore, the major problem is pain. We have discussed pain. We have fatigue, physical weakness. We have lymphedema, dyspnea, and constipation. I remember we talked about constipation when we talk about some of the treatment like frequent or prolonged treatment with opiate analgesics can lead to constipation. Another big issue with constipation is lack of mobility. When patient is actually not very mobile, he can also have constipation. And another cause of constipation is likely going to be as a result of what? Damage to some nerves. If some nerves are actually that improves motility of the gastrointestinal tract are being damaged, then constipation is going to be what do you call it? Is going to happen to the patient. Where principle of palliative physiotherapy, we reaffirming the importance of good quality of life at the end of life. Therefore, whatever physiotherapists are doing to patient at the end of life, we are reaffirming that he is supposed to enjoy good quality of life at the end of life, meaning that the patient should be pain-free. The patient should be active as possible. The patient should not die of serious, what do you call it, reduction in quality of life. You should enjoy life even at the end of life. The second thing is to provide relief from pain and other painful symptoms. Therefore, our aim in palliative care is to see where there is either cancer-related pain, either musculoskeletal-related pain is being relieved. The third is maintaining physical dependence for as long as possible. Therefore, we try as much as we could to maintain that particular ability to move around, even if it is with a walking aid, whatever it is, for as long as possible before the patient becomes finally bedridden. Integrating psychological and spiritual aspect of care strategy. We are also imbibing the definition of WHO. We are imbibing psychological and spiritual aspect of care. Therefore, we try to assure the patient. We teach the patient coping strategies. We try as much as we could to give a lot of assurance and education on the patient, such that the patient would have a good ending. Then offering support to the family so that they can face the patient illness and survive the period of mourning. Therefore, we can also give moral support to the families. They can so that they do more, and we also want them not to enter depression when the patient died. Then palliative physiotherapy. What are our interventions for individuals that are at the palliative phase of cancer? The first one is we want to improve physical function. A study by Navarro et al. Revealed that physiotherapy improves functionality, independence, and skills for activities of daily living in this sample of palliative care unit patients. What they are saying here is they study samples some palliative care unit patients that are suffering from terminal illness. They subjected them to strengthening exercise. They subjected them to a lot of modalities of physiotherapy. What they found is that our intervention as physiotherapists improve functionality and independence and the skill of these patients. Some of them were able to do some activities of daily living, even though they are at the tail end of their life. Then we have a systematic review by Kante et al. 2021, found that physiotherapy modalities were effective on pain, fatigue, dyspnea, loss of functionality, and the ability to independently perform activities of daily living in terminally ill patients. What they are saying here is systematic review has found that what we do as physiotherapists to patients, all the modalities we use we are able to have impact on the pain the patient has. The fatigue level is reduced. The dyspnea, meaning the respiratory function, is improved. And the loss of functionality, meaning that the functional ability of the patient has improved. Now we are moving to cancer-related fatigue. What are the studies that reported on cancer-related fatigue? A systematic review found that cognitive behavioral therapy and massage improves cancer-related fatigue. Therefore, cognitive behavioral therapy is a different form of therapy itself that one would have to learn it, how to give cognitive behavioral therapy, and massage. They said improves chronic cancer-related fatigue. A systematic an RCT reported that among advanced cancer patients with severe fatigue during treatment, a cognitive behavioral therapy intervention was more effective than usual care in reducing fatigue. Therefore, now left for us as physiotherapists managing patients in the terminal end of their life, researchers now have shown, one RCT has shown that cognitive behavioral therapy improves fatigue, and a systematic review shows that cognitive behavioral therapy has improved fatigue, including massage. Therefore, we should learn cognitive behavioral therapy as a form of treatment that can be done to improve cancer-related fatigue and improve the well-being of patients with terminal illness. Okay, in the terminal ill, Reeves et al. Reported that patients' positioning, relaxation, and energy conservation techniques improve chronic cancer-related fatigue and pain. What they are saying here is that this particular therapeutic positioning that we do to patients, we ask them to position very well. We teach them relaxation techniques. We teach them energy conservation techniques that involves some rest and activity. They say improves cancer-related fatigue. A randomized control trial found that physiotherapy program, which included active exercises, myofascial release. Myofascial release is a form of massage. PNF technique have beneficial effect on cancer-related fatigue, meaning that cognitive behavioral therapy, positioning relaxation techniques, and PNF techniques all have impact on cancer-related fatigue. The next is lymphedema. Usually for patients that used to manage, for physiotherapists that used to manage patients with breast cancer, they know lymphedema is one of their big problems. The breast, the upper limb, that is in close proximity to the breast that has cancer usually become inflamed. Therefore, they have a lot of lymphedema. Physiotherapists used to manage inflammation of that particular upper limb. In palliative care, edema can be treated using manual methods, including compression and massage, meaning that massage is an integral part of management of pain and function in palliative care. The pressure from effleurate massage may also help in draining local tissue edema and induce local and general relaxation. They said complete decongestion therapy. This decongestive therapy include lymphatic drainage, compression garments use, like all these elastic garment that we use in the leg with of patients with spinal cord injury. Skin care, a range of motion exercises do help in relief of lymphedema. Therefore, you can do the decongestive therapy, lymphatic drainage, compression, range of motion exercise, add massage. All these ones can work for the patient. And finally, we have respiratory impairment. Therefore, one of the big problems associated with terminal ill patient is the issue of respiratory impairment, dyspnea, at times pneumonia. They become bedridden. Usually, these patients also have problem with immunity. Their immunity is very low. Therefore, they have impairment of respiratory function. Therefore, one of the best treatment methods we can give for them as therapists is to maintain mobility for as long as possible. As far as they are walking and they keep walking, they will maintain respiratory function. We have chest physiotherapy, post-sleep breathing, respiratory muscle training, therapeutic positioning, active cycle of breathing, all can help these patients. Then we have chest clearance technique. There are so many clearance techniques that physiotherapists can do: huffing, coughing, shaking, vibration, postural drainage. Therefore, all these are techniques that physiotherapists can do to help patients. In conclusion, we want to say that physiotherapy is an integral component of palliative care. There is no patient that will be bedridden because of terminal illness that physiotherapist will not be involved. What physiotherapy does is that it ensures adequate pain relief, physical independence, and good quality of life of the terminally ill patient. I want to thank you for listening.
Thank you very much, Prof, for the presentation. And
thank you.
I'd like to open the floor up for questions, comments, and contributions from the audience. So the floor is now open. You can post your questions in the chat section, or you can raise your virtual hand and make your submission. Thank you very much.
Thank you, sir.
Hello.
Okay.
Hello.
Hello, I'm with you.
Okay. Yes. Thank you. Okay. Should I go? Sorry, through the chair.
Yes, you can come, please.
Okay. Thank you very much, Prof. Badaru, for this very excellent presentation. And why am I so glued to my computer is because at Kuala Lumpur, towards the tail end of my PhD,
yes.
The last 3 years of my PhD, I did an internship in what is called Keepable Cancer Community Care, which is owned by one of the physiotherapists, Professor Lo Suyin, that we happen to be in the same, Center for Population Health. What I found very intriguing and extremely interesting, and it became very clear here that all the researches that you shared are not, are not indigenous in Nigeria. And I can tell you from the experience that you have, sir, that palliative care should actually be adaptive, should reflect our own ways of life. Now, Cancer Community Care was able to do a lot. In fact, there were a lot of inventions that they were able to make in managing oncologic pain. I served for 3 months in that center, which is very close to where I live. And I happen to be there every day, for the 3 years because of the interest that I have. What I'm saying here, it provokes this very deep, passion in me to see that perhaps, because this is not what I pursue at the moment, but I think we should have a recommendation at the end of this lecture to actually come up with something that is clearly for us here in Nigeria. Beginning from the researches that you share, you realize that none of all these are imported, literatures, which we need to also ensure that we have our own. It calls for research in this area. It calls for us to, because sincerely speaking, cancer is a public health issue, as you started with that. Oncologic pain is also very apparent, and I think we need to do something about it. So why I'm saying this is that lectures like this should not just end with, with some professorial reflections like you gave, but it should also have some recommendations that we should actually put forward to also engineer some kind of advocacy that will ensure that we start to have this kind of centers in our own domain. Keepable Cancer Community is run by an academic university of Malaya, where I had my PhD. And I think we should also do the same. Perhaps I know, of course, there is funding is the case. I know, but increasingly we are seeing some kind of responses from different quarters. What I can tell you is that because I work in the NGOs, there is a shift now in the funding for NGOs. If you realize, in the last 2 years, NGOs are now pushing their money, one, to grassroots communities, and two, to academia. In Bayero University, I have seen, in fact, somebody was telling me that there are some departments that are gaining funding, writing, grants winning from like Bill and Melinda Gates Foundation, Aliko Dangote, and just yesterday we saw that Aliko Dangote has dashed 1 trillion naira, for health and education just yesterday, and I think it's in the news. Everybody have heard that. He said it's for health and education. So monies like this we should be able to encourage writing grants, because what you presented, sir, is extremely beautiful, and I think we need to chat with, because there is nothing done in this area. And I also call on researchers in some of these areas to please lay hands on this, come up with clear, culturally and domain-specific ways of managing oncologic pain in palliative care. Thank you very much. Sorry, let me allow others to speak. It's just because of the passion that I have for this, and like I said, the 3-month internship that I did in Capable Cancer Community Care in Kuala Lumpur. Thank you very much.
Okay, thank you. So if I want to add, actually, it's good that we have people that have first-hand experience on the, what do you call it, oncologic management, management of oncologic pain firsthand from somewhere abroad. The major issue we have in Nigeria is, do we say that the greatest move to create an oncology unit usually comes from the hospital, just the way we have a geriatric unit? That is when I felt that probably we also have to put heads together with our colleagues in the medical field to come up with research groups and to also see if the hospital can give, can develop or can establish an oncology unit where physiotherapists and other health professionals involved would also begin to. Although I know now, presently, our people are involved in management of cancer in various hospitals, but I think there is no unit called the oncology unit. And I felt that with time, with collaborations, with people like you that have gone to other places, have ideas, we can come up and team up together with other people, with other colleagues in the medicine, so that we can have oncologic research unit, oncologic treatment unit in the hospital, and also have people who are interested in becoming oncologic physiotherapists. Thank you very much.
Thank you, sir. Any more questions or comments before we wrap up the presentation? Professor Badaru?
I'm sorry, can I still come in? I'm very sorry.
Yeah, go ahead, sir.
Okay, thank you. Yeah, thank you very much, Professor, sir. But just to say that, yes, I agree with you, sir. The recommendation that you put forward is largely the clinical management of oncologic pain. I don't mean that, because palliative care is also, it also involves some development of community-based initiatives. The one I told you, the Capable Cancer Community, is actually been put forward by an occupational therapist. Professor Lo Suim was an occupational therapist, and then what she did is for her to have a grant, and a sort of grant from the academic environment that let her have that kind of an NGO. But it's an NGO, academic NGO. I mean, the NGO linked to the academic, to the university. That's what she had. What I'm saying is this,
okay,
and this was
I understand
CCMAS. Yeah, this was in CCMAS, sir. If you look at CCMAS, the reviewed curriculum for physiotherapy, sir, you realize there is there's public health 1, which is going to be taken in level 5. There is public health 2, which is taking which is supposed to be taken in level 6. Because I just reviewed that CCMAS to be able to glean what we can come up with. So you see, this is as much as possible to be able to empower us, especially not only to be the first contact with the therapist, but to be able to think globally. And I think this is why global health is part of what physiotherapists are now tilting towards. We can have funds, have grants to develop community-based initiatives for management of oncologic pain. But I agree with you, there is nothing that multidisciplinary cooperation when it comes to clinical management of oncologic pain. But this one I'm talking about also beyond clinical, because palliative care can also be beyond clinical. There are a lot of palliative activities that are beyond the walls of the of the hospital, which the therapists also have an integral role to play. So this is just the information that I wanted to give.
No, actually, I now understand. I thought probably that particular palliative care unit was a hostel-based unit. Okay, no. It is a community-based palliative care unit. Therefore,
exactly.
There is no, yes. And actually, it's a good, information. It is telling us that we can also do the same.
Yes, sir. Yes, sir. Yes, sir. Thank you.
Therefore, thank you very much.
Thank you very much for that. Very, very innovative. Thank you.
Thank you.
Thank you very much, Dr. Ash and Prof, for the comments. Any more questions and answers before Dr. Awal takes over? Questions or comments, please? Okay, in the absence of any questions or comments for Prof, I'll call on Dr. Awal to take over and give us his own presentation. Dr. Awal is an associate professor of neurophysiotherapy at Bayer University, Kano, and he's trying to sort himself out. I will come online right now and he will start the presentation immediately. So bear with us as he sorts his connection issues and come online, please. Prof. Awal will be using Dr. Muhammad Aliyu Abbas' profile for the presentation. They are in the same office since he's experiencing technical difficulties. So he's starting off. Yes, we can see your presentation, sir. Please go ahead.
You can see me as well, right?
Yes, sir, we can.
All right. So good afternoon to everyone. As it was introduced, my name is Awal Abulai, and I'm an associate professor in physiotherapy here at the Bayer University, Kano. So I'll be talking about nervous system pain, and I'll talk about its evaluation and also treatment. But of course, I see this area as actually a very diverse area, and we cannot just talk about that in just 3 hours conversation. So I decided to, focus on some of the interesting cases we see in our clinics, and I will talk about them. And after that one, I will also talk about neuroplasticity as relates to pain modulation. So these are the things I will talk about. So I'll just go straight to the point. Let me see my next slide. Sorry. Please, I'm coming. Papa! Can you hear me, please? Hello?
We can hear
Hello?
you. We can hear you, Prof.
I don't know why my slide is not let me call Buffer please, okay? Buffer! 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 Now put it back here. Put it back here. Just press the screen. On the screen, right? Where? Touch on the screen. Okay. Touch it like this. Okay. Pokemon, just click on that. Okay, it's okay. So I'll go to the back, right? Let me go. Okay. So what am I doing? If I want to go back, what do I do? Okay, so thank you. Home, right? Just okay. So thank you so much. All right. Sorry. Yeah, it's okay. Please, apologies for the little disruptions. So, like we all know that pain is defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience, which is actually associated with or resembling that associated with actual or potential tissue damage. So we have pain because of actually two things. One, either actual tissue damage or potential tissue damage, right? So these are the reasons why we actually have pain. And people will now wonder, why do we actually have to talk about nervous system pain, while we know that actually the nervous system itself is what controls processes pain. So why do we actually particular about what about nervous system pain? So I'll talk about that one as I move, right? So when we say nervous system pain, we are particularly concerned with pain that results from damage, direct damage or injury to the nervous system. Unlike other pain that nervous system can transmit, maybe musculoskeletal pain and other pains from other organs of the body. All those ones are pain as well. But any pain that results from direct damage to the nervous system itself, in particular, the somatosensory system, we now call it what we call it pain in the nervous system pain, so neuropathic pain, and it's also termed as neuropathic pain, and it can involve different parts of the nervous system, the peripheral nervous system, the spinal cord, and the brain, which are the central nervous system. Example of this pain includes post-stroke central pain or central post-stroke pain, complex regional pain syndrome, and pain in diabetic neuropathy. So for convenience, actually, and because I already mentioned that actually nervous system pain is actually a devised area, so I'll focus on central post-stroke pain. And I said it's for convenience because this is an area I've done quite a number of work on. So I think it will be much easier for me to talk about it. And also, I believe stroke is one of the most prevalent conditions that we see as physiotherapists. And of course, is the third most important cause of disability among all conditions. So I will talk about central post-stroke pain. So what is actually central post-stroke pain? Maybe I didn't mention this. I would like our conversation to be a little bit interactive. Please, before I talk about central post-stroke pain, I would like to hear from some of our colleagues online now, if there's anybody who had an experience with managing this condition, so we can. Please, anybody, please, can volunteer. Anybody, please. Hello. Hello. If you can, yeah, please. Yeah, I'm asking if among the audience, among the participants, if there's anybody who has had experience with managing central post-stroke pain, please. I just want to hear from him, and all other members will also hear from him. Yeah. So anybody, please. Anybody, please? None? Hello. Okay, so I will just go on straight. So when we say central post-stroke pain or post-stroke central pain, anyone you call it, is actually the same thing. And it's also known as thalamic pain syndrome or Dejerine-Arrowsy syndromes. All these are names for. And Dejerine-Arrowsy, they were the ones that discovered this pain, and that's why it was named after them. So it's actually a type of pain that occurs in patients with stroke when the central somatosensory pathways are disrupted, are impaired. And these central somatosensory pathways are what? Are the dorsal medial lemniscus and anterolateral pathways, right? So when they are actually affected or impaired, our patients usually come with this symptom. And the way you know that a patient is having central postural pain is, one, the patient complains of constant or intermittent pain, which is actually usually associated with other sensory abnormalities such as perception of very harmful or sharp stimuli, and also anxiety, depression, and also fatigue. These are also associated with. So that's what actually differentiates it from other pain conditions. Although it's actually really, really very difficult clinically to differentiate between one pain and the other, but we see when we go when we move on. Then, why are we actually concerned about this kind of pain? Because this pain is actually very, very debilitating, and it can affect people's ability to carry out their own daily activities daily living. Imagine someone had a pain, but as a result of that pain, the patient cannot even be able to use his hands to carry out certain activities, so maybe writing, even eating with the hands, or maybe he cannot use the leg to actually walk. So actually, it's actually a very important symptom that we need to actually consider, understand it, and actually know how we can manage clinically. Another thing it actually causes is actually associated with what? Emotional disturbances such as depression and anxiety, and also other conditions like fatigue. And as such, it's actually an important cause of decrease in the quality of life. Yeah, we can see that in this slide, I talk about its prevalence, that it ranges between 1 to 12%. Unfortunately, this is actually most of the studies that reported on this are clinically hospital-based studies actually. So you don't expect to see so many participants in those studies, but they actually found out that the prevalence actually ranges between 1 to 12% on patients with stroke. But I do argue as a scientist, as a clinical scientist, I think I do argue because I believe that the percentage prevalence should be much, much higher than this. And maybe one of the reasons why we see this small percent, a little bit relatively a small percentage, maybe because of one thing. One, clinical is actually very difficult to differentiate between one pain from the other. It's actually very difficult, actually. That's number one. Number two is that in our own routine clinical practice, we don't screen our patients for central postural pain. Once they come to the clinic, we only ask them, okay, do you have any pain in the body? So, okay, I have pain in the shoulder, I have pain in this and that, but we don't mind actually to use screening instruments for neuropathic pain to know that this patient is having central postural pain. Maybe the reporting of this, that's why the reporting of this actually is actually very, the report of this case is actually very, the percentage actually is not really on the high side. Number two is that it results from stroke. And when our patients come with stroke, we focus mainly on helping them to achieve movement recovery so that they can be able to perform their activities daily living. Yeah, we are concerned with their movements, how they move, how they walk, how they use their hands, and all that, isn't it? How they transfer and all that. So probably one of the reasons as well. Then again, another reason is because as soon as we see patients, we design rehabilitation for them. And those rehabilitation techniques that we actually design for them also help in inducing neuroplasticity, which also helps with resolving sensory impairment that the patients may also have. So probably this could be part of the reasons why we don't see, yeah. Like in Halluru et al., done by one of our students here. I'm part of the author anyway. I was the supervisor. We actually found out that the prevalence is actually about 5%. So from the same study, if you can look at it here, from Halluru et al., what we were able to find, we were able to see the characteristics of patients with central postural pain. And if you can see in the pain location, usually it's usually hemibody. Actually, it occurs in the half of what on the contralateral side actually. Yeah, hemibody, contralateral hemibody actually. And the pain can be in the inferior upper limb. It can also be in the inferior lower limb, in the leg and foot. You can see the number of people that actually had among our participants. And it can also occur in the superior upper limb, in the arm, in the lower limbs, in the hands, in the shoulder. And the onset of the condition actually, usually in some cases it starts immediately after the stroke, and in some other cases it starts within 3 months after stroke, and even after 6 months post stroke. So it can occur actually at any time post stroke, and the pain intensity actually varies. It can be severe, it can be moderate, but in most cases, it's severe and moderate. You don't usually find patients with just mild pain intensity. Then the pain frequency can be continuous, can be intermittent. And the intermittent type, it usually comes as a very sharp pain, or maybe shooting pain, and it just subsides for some time. But it can also be continuous throughout the day. The patient feels it and all that, unless if it's been distracted by another thing. So, continuing with the characteristics of the pain in the next slide, you can see that, like I mentioned, it can be an intermittent. The characteristics of the pain can be burning sensation, can be freezing sensation, can be scalding sensation, and it can be a tingling sensation, it can be a throbbing sensation, it can be an aching sensation. It might also be an electric shock-like feeling. Then it can also be what is squeezing sensations, and it can also be a prickling sensation. So these are the characteristics of what? These are the characteristics of the dependent characteristics of patients with central post-stroke pain. And like I mentioned earlier, I don't know, maybe I mentioned it earlier. I said in these presentations, I will focus mainly on the evaluation of the condition and also on its management. Yeah, I believe pain and its mechanism was talked about last week by the first presenter, who was a consultant anesthesiologist. So there is no need to reinvent the wheel. So I'll go on particularly to talk about the evaluation, so that we see how do we evaluate our patients with this condition when we see them. How do we actually evaluate them? So that's what we look at. So in evaluating any patients or assessing any patient conditions or symptom clinically, the best way is to consider the patient holistically. So when you look at this is what an International Classification of Functioning and Disability, ICF model. So if you look at it on the top here, we have the health condition, which is what? Which is the stroke. Then we have what? Impairment, which is what? Which is the central post-stroke pain we are talking about. Impairment in body structure and functions. Then we also have what? Activity limitation. And we also have participation restriction, which can all be affected by what? By personal factor and also environmental factors. So for this evaluation, for this lecture, I will talk about how we can assess the impairment to know that someone has central post-stroke pain, and also talk about a little bit on how that impairment affects activity limitation and also affect participation activities and limit activities and also affect participation. I can give an example. If someone has severe continuous pain in one half of the body, let's say the right half, that can affect the way he works. Maybe he's the one that doing his laundry. That can affect his own ability to carry out, limit his ability to carry out laundry. And another example I can give is someone has severe, continuous, maybe freezing sensation, so scalding sensation or burning sensation in the lower leg, in the legs, for instance, one of the leg in the hemi part of the body that the stroke affected actually. He may not be able to walk. Even if he can walk, he may not be able to walk a long distance, and that can limit his participations and all that. If he wants to go to the mosque, if he wants to go to the church, that will affect how he does that. So it's actually good if you look at both the level of impairment, the disability, which is activity limitations, and handicap, which is the participation restrictions. Yeah. So, and another thing I will mention here is that sometimes you manage pain, but the pain, because of maybe the article measures you use to assess the pain, or maybe because the patient is not able to realize that the pain has subsided, you can also know that your intervention actually worked if you checked activity limitation and also participation restriction. Maybe the pain has not subsided from the patient's perspective, but if you can really reflect, you can see that now maybe initially before they started the treatment, he was not able to walk down 200 meters, maybe 200 meters. But now you can be able to do that, which means even if the pain, as reported, the patient has not subsided, we have been able to improve activity and improve activity limitations. So that's actually a good sign. Or else we may also be able to. We have also been able to improve participation. The patient is not able to attend weddings, is not able to go for his work. Maybe he's a carpenter, but now even though the pen is still there, but he's not able to do his carpentry work. Yeah, so it's good to what? To look at the patient holistically, but assess impairment, assess disability, and also assess handicap. So I'll start. The first thing that you would do if you're evaluating or assessing patient with central post-stroke pain or post-stroke central pain, I'm really very sorry. It's like I mixed the two alternative names. Sometimes I call it central post-stroke pain, and sometimes I call it post-stroke central pain. But please take note that they are all the same thing. So the first thing that you do is to do history taking, and in history taking you have to actually find out the type of stroke the patient had. People can have central post-stroke pain because of any type of stroke, be it ischemic, be it hemorrhagic. But ischemic actually, in most cases, people that have this condition usually have ischemic stroke. Then you also look at the lesion of location. Yeah, so the lesion in the brain usually is actually usually in the thalamus. It can occur in other places, but usually in the thalamus, and that's why it's one called thalamic pain syndrome. Then you also look at the time since stroke. When did the patient had the stroke? Was it 1 month ago? Was it just yesterday? Was it 1 year ago? And so you need to take that actually. And you also need to take note of the pain characteristics, which include the onsets, right? When did it actually start? Yeah. There's difference between the stroke onset, the time since stroke, and the pain onset, right? One may have just stroke and may not actually develop central post-stroke pain until maybe 3 months later, 2 weeks later, 6 months later. If you look at the first slide we shared, one of the slides we shared from one of the work of our former students. You also need to You also need to know the intensity. Is it very severe? Is it moderate? Is it mild? You also need to know factors that actually exacerbate the pain, factors that provoke the pain, and factors that may relieve the pain. It's possible that the pain gets relieved when the patient does physiotherapy exercises in the gym, maybe. Probably the pain gets provoked after the exercise. So you need to all know those things so that you can advise the patient accordingly and also plan for treatment. You also need to temporal characteristics. Actually, what time the pain actually is more severe, or what time the patient actually feels the pain. So you need to actually talk about look at that. I mentioned this. You also need to ask the patient about any activity limitations. The patient should tell you what are those things that they have not been able to do since the pain started, or what are those participations that they are not able to do since the pain actually started. Maybe they were able to go to the mosque and pray, go to the church and worship. But unfortunately now they are not able to do that because of the pain. So you ask those ones, and these are the things that will tell you when you're giving treatment. So yeah, is your patient improving? Not only the pain itself. Yeah, so we'll talk about that when we come to management. So talk about that. So I'll go to the next slide, please. Anyone wants to? Is there anyone that wants to contribute anything, please, among the audience, the participants? So I'll move on. Okay. So you can also do other tests. You can test for sensation. Yeah, and you can also do other tests that we'll talk about in the next slide. We'll talk about the tools that we can use to screen whether the patient has neuropathic pain or not. So we'll talk about that. I think that's one of the most important things of the lecture today. So in sensations, we can look forward. We can test for lemniscal function. We can also test for the function of the spinothalamic tract. So in the lemniscal functions, we test for proprioception. I think this one is an easy thing. Almost everybody in physiotherapy does that. Then we do light touch sensation test for light touch sensation, and we do also test for vibration. I think I may ask the audience or the participants on how do we actually carry out vibration sensation test, please. But is there anybody that can volunteer to tell us about that? Hello, audience, please, participants. Are you with us, please? Somebody can put on his audio, please, and respond to me, please. It's good that we make it interactive so that we learn one thing or the other. I shouldn't only be the one who does the talking, please. Hello. Okay, I think this audience are not ready to interact. Okay. No problem. So in vibration sensation test. Hello. Hello.
We are listening, sir.
No, it's like someone wants to say something. Okay, I think it's a side talk from elsewhere. Anyway, it's okay. For vibration sensation test, what we do is that we use the turning fork. I think turning fork is actually a common thing because everybody knew it right from secondary school. So what you do now, you just like, let's say this one. I think people that can see me. Let's say this is the turning fork. So you use one part of your body, maybe just strike it on your forearm, and it vibrates. Then you now take it, the lower side, and place it on what? You place it on a prominent bony area on the what? On the patient's body. In particular, you can start with the thumb. If you use the leg, you can use the thumb. Yeah, the interphalangeal joints. You can do that, right? You just place it and you ask the patient. You ask the patient to close his eyes. If he closes his eyes, then you ask him if at all. Okay, ask him first of all to close the eyes. Then you now what? Place the turning fork on the bony area, and you ask the patient if he feels any vibration, when he starts feeling any vibration, and when the vibration actually stops. So let's say you are starting with the thumb of the right lower limb, and the patient tells you that he didn't feel anything. So you don't stop there actually. You move out to what? To the proximal part of the body. You can go to the what? You can go to the ankle joint, maybe to the malleolus, any one of the malleoli, any one of them, because it's a prominent bone. You also test that. If the patient tells you that, if you now find out there is a loss of sensation, the patient didn't feel when the vibration started and when it stopped, then you move up. You move up to the what? Another bony prominence, probably the shin. That's for the tibia, the prominent part of the bony area of the tibia. You do that as well. And as you go up until you get to what? Even to the sternum. Yeah, so once there is a loss of sensation, then you move up. You check all the prominent bony areas of the body till you get to the sternum. That's how you actually do that, I think. So this is one of the things that I want to add. But the spinothalamic tract, this one is just an easy stuff, and everybody does that. Then you also look for what? You look for what? Increase sensation. That's what we call hyperalgesia. Increase sensation to what? To maybe light touch or maybe to gentle pressure. That's hyperalgesia, and it's different from allodynia. In the case of allodynia, it's what? Sensation, feeling of pain, as a result of what? As a result of an otherwise non-painful stimulus. Yeah, maybe gentle stroking. If I do gentle stroking on your forearm, definitely it shouldn't be painful actually under normal circumstances. But if someone has allodynia, if you just do a simple gentle stroking on the forearm, he feels as if what? As if a painful stimuli is being what? Is being introduced to his body, and he will feel it as a painful stimulus. That's allodynia. Then the next thing we'll talk about is what? Is use of what? Assessment tools for central post-stroke pain. And one of the tools that is actually used to screen for central post-stroke pain is called the what? DN4Q. That's Dolo Neuropathic 4 pain questionnaire. 4 questionnaire. It's a questionnaire that consists of what? 4 questions. It consists of 4 questions, and those 4 questions actually consist of what? 10 items. The first question is asking about, does the pen have one more of the following characteristics? So if it has any of these characteristics, the patient is what? Expected to say yes or no. If it doesn't have it, say no. Now you ask, okay, does your pen burning? If it's burning, the patient will not say yes. Then you tick. So the patient has scored 1. Then if the what? The pain is painful cold sensation. You ask whether the pain is painful cold sensation. It is painful cold sensation. The patient will say yes. If it's not, is a no. Then whether the pain is actually like electric shock, is electric shock like a feeling. If it is that, the patient will say yes, and if it's not, the patient will say what? Will say no. That's for what? That's for question one. That means the question one consists of three different items: burning sensation, painful cold sensation, electric shock sensation. Then the question number two also has what? Has four different items, and it's asking whether the patient has these four types of sensation. Is the pain actually tingling sensation? Is it pins and needles? Is it numbness? Is it itching? So if the patient has all these things and has any one of them, he will say yes. If he doesn't have, he say what? He will say no. So looking at this questionnaire alone will tell you that uh, central postural pain is actually has so many different characteristics. In one patient, they may have burning sensation, painful cold sensations. In other patient another patient may even have most of these characteristics, may even have all, and another patient may have just what, just have one. Then the first two questions, which consists of what? Which consists of 7 items, are interview of the patient. You interview the patient himself. But the last three questions, which are what? The last three items. The last 3 items, which are in what? Question two are in question two, question three, and one is in question four. Are what? Are questions that the therapist perform carry out examination to find out whether the patient has those characteristics. So one in question three, is the pain located in an area where the physical examination may reveal one or more of the following characteristics? So you do physical examinations and you now what? You now test for what? Hypoesthesia to touch, right? So you ask what? You touch any part of the patient body and now find out whether the patient has reduced sensation to touch, or what? The patient has hypoesthesia to what? To pinprick. Or maybe the patient has what? Reduced sensation to pinprick. So these are the two things you look at. You are the one that will perform. You ask the patients, right? Isn't it? So if he has reduced sensation to that, then you know what? You now give them 1-1. If it doesn't have, you now give them what? 0-0, which is actually no. Then question 4 is what? In the painful area, can the pain be caused or increased by brushing? So in that painful area, the patient has the pain. If you now brush that area, is the pain being what? Is the pain being what? Is the pain increased by what? By just mere brushing, which more or less is just testing what? Allodynia, right? Isn't it? So if the pain is what? Is increased by what? By mere brushing, it means the patient has what? Has probably, you begin to suspect that actually. So if he doesn't have, you now give him what? You say no and you give him 0. So after everything, what you do now, you now sum up the scores. Let's say the patient has 2 years in question 1, has 2 years again in question 2, and has 1 year in question 3, and maybe a no in question 4. So that means the patient has scored what? Has scored 4. So the way to interpret this score from this questionnaire is that any patient that scores 4 and above is out of 10, because you can see the items are 10, even though the questions are 4, and that's why it's called 4 questionnaire. The what? The items are what? The items are actually 10. So if any patient scores 4 or more in this questionnaire, said yes to, you found yes, right? Find yes, yes in four places on four of the items. That means the patient has what? Has neuropathic pain. Either pain from spinal cord injury, either pain from central post-stroke pain, either pain from complex renal pain syndrome, all those neuropathic pain. So this actually questionnaire is actually done what? Specific for what? Neuropathic pain, not only specific to central post-stroke, but it's specific to all neuropathic pain. Of course, in studies have shown that this one is actually valid and reliable for use in central post-stroke pain. So, Mikey, please. The total score for this questionnaire is what? Is 10. So if any patient scores 4, from 4 to above, 4 and above, 4 or greater than 4, the patient has what? Is high likely that is what? You now have what? A high index of suspicion that this patient may have neuropathic pain. And in this case, in patient with stroke, we call it central post-stroke pain. So this next slide is also talking about, I just try to just expand a little bit. And sorry, it's not even 10 questions, please. It consists of 10 items, sorry, not 10 questions. The questions are 4, even from the instruments, but the items are what? Are 10. So 7 of those questions, not questions, please, the items are related to pen quality. So those 7 of those items are talking about what? The pen quality. And you ask those patients, the patient themselves, you interview them to describe them. I think we'll talk about this one, so there's no need for us to waste much time on that. But the other 3 questions are what? Are examined clinically by the therapist himself. And the essence of that is to find out whether the patient has reduced sensation, which is what hypoesthesia, or what, or allodynia, that's pain sensation from otherwise non-painful stimulus. Then the total score is 10, and I think I mentioned this one much earlier. So you can also use other tools, the visual analog scale. You can use also the verbal numerical rating scale, which I think every therapist is very, very familiar with. So there's no need to. You can also do that. But in this case, we are not using them to screen whether the patient has what? Patient has central post-stroke pain. So what do? You are using them to find out what? The intensity of the pain, to determine the intensity of the pain. So that when you manage the patient, let's say the patient scored, initially the patient has a score of 10. That's the worst pain, right? Isn't it? And after your intervention, after 2 weeks, the pain reduced to what? To just 5 points, which is a moderate pain. That means you have what? You've been able to achieve something, right? Isn't it? Because there's what? There's about 5-point decrease in the intensity of the pain. So, so that's about that. So another thing you can do, like I mentioned, when you are managing your patient, not only just with central post-stroke pain, the best thing is to look at the patient holistically, not just targeting the impairment. We are physiotherapists, we are clinicians, we are clinician scientists, so we don't only target the root cause only, but we also target the consequences of. Please can you put off your audio button? Okay, thank you. Yeah, so we look at our patient holistically. We don't only target the source of the impairment, but we also look at the consequence of the impairment itself. And sometimes, no matter what you do, the instrument we use, or maybe any test we carry out, they need to be able to sensitively pick out any identify any improvement or any deteriorations in the condition. Yeah, it might not actually do that, but when you when you include other measures of participation, measures of activities of daily living, activities limitation, you may be able to pick up something. Of course, some patients, depending on the kind of treatment you do, we'll talk about that much later. They have to live with the pain, or maybe sometimes for the rest of their life. So if they still have pain, are we going to allow that pain to just limit them? That they cannot they should not be able to live their life the way they want to. They can't be able to carry out their activities of daily living. They can't participate and all that. So there are certain intervention strategies that we can do. The patient will be able to live, even though the pain is still with them. They can be able, they can be able to live as independently as possible. So we need to also assess our patients for their ability to carry out their daily tasks, their daily activities, how they go about their normal day-to-day life and all that. So we also look at that. The pain is not actually limiting them from that. So that's what. So one of the measures I think I found that clinically really very simple. In stroke patients, we use Babel index, the modified one and the older version, but I think it's a little bit cumbersome, and I think I can recommend clinically to some extent for very busy clinicians like you. You can use the CAT index. The CAT index is a measure of activity of daily living. It assesses for bathing, the patient's ability of the patient to bath himself, dress himself, do his toileting, transfer himself, do continence, and also feed himself. So if the patient is dependent in those things, you give him 1. If he's not, so if he's dependent, you give him 0. But if he's independent, you give him 1, right? And the total score is actually a 6 because we have 6 items, and the minimum score can be Can be 0. So depending on what the patient has, then you so if you do that, you can evaluate your patient. Let's say the patient, when he started, he wasn't able to, when he's at the central post-stroke pain, he was not able to use the hand to bath himself or to dress himself or even to feed himself. But now he's able to do that. yeah, you can be able to say, okay, there is what? There is an achievement, there is an improvement to some extent. Of course, here in Kano also, we also developed our own activity of daily living skills. We call it the Kano Activity of Daily Living Skill. And I'm happy to tell you that is what the Geriatric Center in Ekiti has adopted. They gave us a call when they're establishing the center, and we gave them more information on that. And I'm very proud of that because that was done, is a work done by one of my former students actually. So I'm just happy about that. Who is also formerly a staff of the teaching hospital. So you can do that. You can also, if for very busy clinicians, if you think the use of outcome measures can be actually very, very cumbersome for you. We all know what activity of daily living skill is. Sorry, we all know what activity of daily living is, right? Activity of daily living are those activities that we carry out in our own daily life that are actually essential for our living. Things we do, the way we walk, the way we walk with our legs, the way we transfer ourselves, the way we eat, the way we bathe ourselves, and so many things. In our culture here, even the way we perform ablution, actually, the way we perform ablution, the way we go to the mosque and pray, all those things we consider them as activities of daily living. So if you're a patient, initially you could not walk to the mosque and pray, but now after treatment, now is able to go it means that you know that okay, your patient has what has improved. So I recommend that please we look at our patient holistically, not just even including the measures of participation and even measures of quality of life. Yeah. So thank you so much. I think that's the end of the evaluations. I will now move to what? I will now move to management. So in the management, I have been able to somewhat group them into four. There are more than that actually, to be candid. So I call the neuromodulation techniques that you can use. I called another one therapeutic-based exercise interventions. There are also behavioral interventions and others. In this other, I think in particular, I will talk about sensory retraining, and which I think has some good evidence. I've seen some randomized control trials on that, and it's something that very, very easy. In fact, it forms even part of the sensory testing we use for our patients. So I think I will talk. That's almost the last slide, but I'll talk about that. So when you talk about the neuromodulations, under neuromodulations, we are talking about the use of what electrical currents. Though neuromodulation is actually beyond that, exercise is also used for neuromodulations and all that. But when my own definition of term here for neuromodulation, I'm talking about the electrical equipments or magnetic current equipments that are used to modulate to influence the nervous system physiology. So one of them is the TENS. I don't need to actually describe it because TENS is actually a normal thing that we all use. The second one is the transcranial magnetic stimulation and transcortical direct current stimulation. For the therapeutic exercise, we have task-specific training, and one of them, the variant they use. I think we have one study on that for constant induced therapy, and also have a case report of a patient using task-specific training. And if time permits, maybe I will also share the case reports from our team and other teams as well. Then motor imagery, then mirror therapy. I'll talk about these ones. Then for the behavioral interventions, we have cognitive behavioral therapy, CBT. We have acceptance and commitment therapy, which includes mindfulness and all that. And the others, we have virtual reality, biofeedback, and sensory training. So I'll take them one after the other. So first of all, I'll take the neuromodulations. I'll talk about the TENS. So this is studied by Legion and Bovey since 1989. I'm just wondering, I couldn't find so many studies on that, but this one by Legion. And they actually use low and high TENS, high intensity TENS for their patient with central post-stroke pain. And what they found out that they assessed the pain using verbal pain rating scale, the one I showed earlier. And what they found out, they had some relief. They got some of the patients, they got some relief. Actually, it was a case study consisting of so many patients, about 15 of them. So each patient was supported based on his individual presentation. So what they did was that they found out that some of the patients had some relief, even at 20, 23, 30 months for the intervention, after the intervention. So about 3 years after the intervention, the patient got that relief they got actually extended to that period. But unfortunately, in about one or about a third of the patients, use of TENS actually exaggerated their pain initially, but that was actually temporarily. And I think I have explanation for this. The explanation is because what? It could be because of what? Because of hyperalgesia. They actually have what? They actually have one of the symptoms the patient have is what? Already hyperalgesia. Actually, right? They react. They have exaggerated reactions to what? To stimuli. And imagine the discomfort that is brought about what? That actually application of TENS actually brings about. So I think probably that's the reason why they have the what? They have the some of the about one third of the patient initially had this discomfort or pain temporarily, which we consider as what just as an advanced effect. And the mechanism for the actions of these TENS is just get control theory uh, and endogenous release of what of opioids. I'll talk about this one when I come to neuroplasticity. Well, come in, please. Okay. Fine. Presentation. Yes. So the next one is what? Transmagnetic stimulation. Transmagnetic stimulation is what? Introductions of what? Introductions of magnetic current via electrodes to the what? To the brain. Yeah. So in transcranial magnetic stimulations, in one of the studies by this one is actually a systematic review consisting of about 9 studies actually. They actually introduced a series of 20 trains of 5 seconds in durations. With about 5 seconds also intertrain interval at a stimulation rate of 10 Hz and 80% of resting motor threshold intensity. When they introduced to the brain, it was found out that these patients actually had reduction in central postural symptom in favor of what? In favor of the group that received actually the TMS, right? Then compared to the sham. So they actually included studies that compared those that have actual stimulation and those ones that have sham. In sham, you just apply the electrode without putting it on. So in those that received the actual stimulations, they had what? Reduction in what? Reduction in central postural pain with a very large effect size, which is 1.45. So when we say large effect size, it means when we say effect size, it means what? It means the strength of the what? The strength of the effect. So the effect is actually large. When we say effect size, we are talking about the strength of the effect. We are saying that the strength of the effect of that treatment. The strength of the effect of that treatment is actually very strong, and that's why it's one we call it large effect size. And the possible mechanisms of what of this intervention, though I will still talk about the mechanism when I come to talk about neuroplasticity, is what? One, decrease in central sensitization. So actually, the pain modulation by the central nervous system. Actually, there is actually increase in central sensitization. We'll talk about this. It's part of the thing we'll talk about in neuroplasticity. Then also increase in what? There's also probably there's increase in expression of anti-inflammatory cytokines, substances such as interleukin 10 and interleukin 4. This is one of the reasons. And also there's also decrease in what? Decrease in expression of pro-inflammatory factors such as interleukin 6 and tumor necrosis factor 1 alpha. So next slide. So this also what? This is on the TDCS, transcortical direct current stimulation, and this is from one of our teams also, and it's also led by one of our former students also, in fact, 2 of our former students. And so it's what actually locally made evidence by my colleagues, consisting of some of our colleagues here, and also myself. So what was done here, it was a case report. Maybe if time permits, I also share the case report of the patient. It was a woman with central postural pain and depression, and transcortical direct current stimulations of 2 millimeters ampere, 2 milliampere was given to the patient was applied to the patient's dorsolateral prefrontal cortex, 20 minutes to the right dorsolateral prefrontal cortex, 5 days a week. I think should be for 4 weeks, right? I can see it very well here. I think something is okay. I think it up. Let me take it up here. So for about 2 weeks, actually, that's what was done for these patients. And the patient initially actually resolved, but after some time, it also relapsed. But at 6 months post intervention, the pain actually completely resolved. And the same mechanism also applies to TMS, and even exercise actually applies to the transcortical direct current stimulation. Sorry. Okay. Why is it not going up? Sorry, I'm trying to. Okay. I'm trying to go to the next slide. Can you hear me, Josefa? Hello?
Yes,
Yes, we
sir,
can
we
hear
can
you.
hear you.
Okay, okay. So I'm trying to move to the next slide, but it's like freezing. I don't know. Don't mind me. Okay, thank you so much. Yeah. So we also have what the therapeutic exercise-based intervention that we can give, and I come across a study on constant inducement therapy for those with 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 uh, with central postural pain. These studies actually I'm showing on the slides are not on central postural pain, but they are on constant inducement therapy. It's just for me to explain what constant inducement therapy is. Also I have written a number of work on this, so I'm also in to some extent people who have done work on this. So you can see my citation there, Abdullahi. So for constant inducement therapy, it's actually a therapeutic intervention that involves three important components. There are so many other components of it actually, but these three are most important. One, if someone has stroke, let's say, which affected the right side of the body, what you do is that you constrain the unaffected side, just so as to prevent it prevent it from being used by the patient. So you can use anything. You can use this one she's wearing is called a mitt. You can use hand gloves. You can use, in fact, if you want, you can even use your hand and put it in one of their pockets. And just look like a guy, right? You can also use You can also use a sling, right? You can also deliberately, behaviorally, just not even use the word, the affected limb, and all those are what? All those are what? All those are constraints, right? Yeah. And it's actually done for what? About 95% of the waking hours. So if you are doing constant movement therapy treatment, although there are some modified types now that involves just using the constant for 2 hours during the treatments, or maybe 4 hours a day, 6 hours a day. Yeah, but it depends on your own clinical decision-making ability. As yeah, of course, you are therapists and you can make any decision you want. Then then it was given what? Given usually for 6 hours. The reason why for the constant is to allow the affected limb to be used what? To be used what? Repeatedly. That's what they call the mass practice. And usually for 6 hours during the treatment. Or you can use 300 repetitions. You can count either based on hours or what? Or repetitions. Personally, I actually prefer use of what? Use of a number of repetitions, because that's what I argued during my master's and even some parts of my PhD as well. So these are the things I actually argued. I argued about the use of number of repetitions to count the intensity and the dosage of the rehabilitation rather than just using hours, because other people will just sit in for 6 hours. Can just sit down and do nothing. But when you tell them, okay, you have to do 300, they'll find every means to actually do those 300, and you do it for 2 weeks or more. It can be given for 2 weeks or more, depending on what, depending on the severity of the affectations of the motor system. Then transfer package. Transfer package is just a contract that you do. Say, okay, my patient, please, between me and you, I just want, when you go back home, whatever you do that involves use of your limbs, whether the upper limb or the lower limb, please, I want you to use what? Try as much as possible to use the affected limb. And all these things, if you look at the constraint, the other unaffected side is being constrained, and you're asking somebody to make sure that he uses his affected limb throughout the day, even after the clinic. You're only encouraging what? You're trying to encourage the intensity of the what? To have a high intensity of the practice. And of course, one of the key factors for recovery after stroke is what? Or every other and even other neurological conditions is what? Is the intensity of the rehabilitation. Is the intensity, how much is being done. Yeah, because the brain gets remodeled through what is called the use or experience dependent plasticity, isn't it? We'll talk about that one a little bit, right? But someone will tell me it's not every patient that has that is able to use his limb, that has the motor ability to do these things, these tasks, whether for the lower limb or for the upper limb. It's not every patient. Someone will tell me that. Yeah, of course, we have another version for this. Of course, if you are sick And there are some tasks you cannot be able to do on your bed. Even taking your bath, you can take your bath on your bed, right? So the same thing. If someone is having what? Some inability to use the limb, either the lower or the upper limb, even to some little extent, you can do what you call the mental practice. By mental practice, it means what? It means the patient mentalizes, the patient imagine that he's those tasks. Not only mental practice, you can do what they call motor imagery, which consists of the mental practice and task observation. The patient will first of all observe someone, maybe a video, or maybe physically observe someone, or maybe observe his unaffected limb. Do the practice with unaffected limb, then observe that. Then he now mentally within his mind will practice as if he's doing those ones. And there is also what neurophysiological basis of that. So you can do motor imagery for those that have severe impairment that they cannot be able to use their hands or the lower limbs. But the key points when you are doing this, the patient has to practice what? With so much high intensity. If you are doing repetitions, at least from 300 to 600 per day. For the lower limb, up to 1,000 per day. And that's the main basis for the use of treadmill actually training. So, okay. Okay, Tom. Yeah. So I found one study specifically that talk about the use of constant inducible therapy in patients with central post-stroke stroke pain, and it's by Stone et al. And it was even published this year, 2025, and they included 221 participants. Although in the study, only 120 participants used the constant inducible therapy. So what they did intensive mass practice for 6 hours a day. Yeah. So and they divided it into what? Into 8 sessions per day. One session they spent for 5 minutes, and another second session till they get to. In each session they spent for 5 minutes, and they did that for 10 consecutive days. And they also assessed pain using what? Using Fugl-Meyer. And Fugl-Meyer motor assessment, although is a mode, is a measure of it's a major motor function, but not only measure of motor function, it's also a measure of what? Sensory motor impairment. So and that's why they use it to assess pain, because there's a component that actually assesses what? Limb pain. So what they did was, when they did that after 10 days, they now checked and they found that the pain has improved and the range of motion has also what? Has also improved. The same constant inducible therapy that we talked in the earlier slide. And the physiological mechanism of this is actually use dependent plasticity. The experience what? Dependent plasticity. I'll talk about this in neuroplasticity when we come. Then this is another study also by my humble self. In this study, what I did was I had one of my neighbors who had central post-stroke pain, and he just came and met me. That was around 2015, I think, if I remember, or 2016. And he came down with central post-stroke pain, which was very, very severe, very debilitating, and I think he wasn't able to do a lot of his, even to wash his clothes, he wasn't able to do that. So what I did was I just sent him for treatment in one of the near hospitals, but unfortunately he was also referred to see a neurologist, and he came. He didn't have money to manage to afford that. So what I did was just to make a compromise and saw him in the neighborhood, and that's what happened. And I was able to present this one as the Nigerian Society for the Study of Pain in 2000 and probably 18 in their conference, and also published this one as a case report. So if you look at this slide, these are the tasks I asked the patient to do. So for the upper limb, I asked him to do this task, picking up a cup and drinking from it. I asked him to make as if he's brushing his teeth. And each of the tasks, I asked him to do the task 20 times per session and 3 times in the day. So he did use three sessions, one in the morning, one in the afternoon, and one in the evening. So 3 times, 20 times, and 7 times a week for 4 weeks. So he did every day because he wanted to really get better. For the lower limb also, I did stepping exercise, forward, backward, sideward, and inward stepping, and 25 times each per session. 3 times a week, 7 times a week for also 4 weeks. And the patient actually got better. So I will show the results. So these are the results. So I used 2 outcome meters. I used the VAS, traditional VAS that we normally use. So if you look at that time the patient came, this was the pain intensity, about 10. That's what they call it. Just show the severest point. Then by 2 weeks, it has reduced what? It has reduced to 4 points on VAS, which means a 6-point decrease. and uh, 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 by I think this should be 3 weeks, right? I think by 4 weeks. I'm sorry, the third measurement by 4 weeks, the pen has already got abolished. And for the DN4Q, the Dolo neuropathic question that I used, even though that one is also mainly used for screening, but I still managed to use it for what for the uh, pre and post assessments. And if you look at this patient, and that he also scored the maximum, which was a point of 10, but by 2 weeks, the score on the DN4Q changed to just 2 points, which means what? Which means the patient doesn't have CSP again, because you must have a score of 4 or more for you to have central post-stroke. But of course, by the 4 weeks, everything has uh, got improved completely. So another form of exercise-based intervention we can use is we can use the mirror-therapy, right? Mirror-therapy, our own traditional mirror-therapy, right? So Kobeta et al. In 2018, he also is for a patient. This is a case report, and I will talk about the unfortunate side of management of central post-stroke pain when I come to the maybe part of the conclusions. I will talk about lack of studies, lack of ideas on that and all that. I will talk about that. Then Kobeta et al. Also is so a patient, and this is what they did for the patients. They use they place a symmetrical they place what? They place a mirror between the two arms of the patients, right and the left. But they slanted towards the what? Slanted more towards the affected side, so that the patient can be able to see through the principle they call lateral inversion, right? We all did that in physics and secondary school. So when you look at mirror, when you put your right hand, when you put your left hand in front of the mirror, so if you look at it, it will appear in the mirror as if it's what is the right hand. That's the principle of lateral inversion. So this kind of intervention is actually done to what? To help modulate the sensory networks in the brain, so that the patient can have an illusion that the hand is reflecting in the what? In the mirror. Of course, it doesn't have sensation in the what? Any pain sensation in the unaffected side. So if you look at it in the mirror now, it will now look as if it's what? Is his on what? Is on right, on the affected side, actually. So that may help in what? Reshaping the feeling of the perception of the feeling the patient, of the pain the patient actually has. So what they found out, actually, they found out, um, um, initially the patient had what? Patient had 4.5 points reduction in VAS after the treatment, had about 4.5 points reduction in what? In pain, as measured using VAS. Of course, 4.5 5 points reduction is almost about half, about 50% of pain. Assuming if the patient has what? If the patient has a pain of 10, a score of 10 on VAS, and now it what? Gets reduced by 4.5. I think that one is actually a very, very remarkable improvement, right? That's during what? During at hand at rest, and 3.4 point during a maximal squeeze left hand contraction. That's if at rest. But if the patient is squeezing his hands during maximal squeeze left hand contraction, he now found out the pain is what? Is reduced by 3.9, a little bit less than, because here is doing an activity, it's contracting the muscles. So definitely they might produce some pain, and that's why it's so this is an example of a pictorial example of the mirror therapy. You can see the patients here. So this right hand is the unaffected hand. The left hand is the affected. So he's just looking at, you can see, yeah, he's just making a fist here. So you can see the right hand here is reflecting as if the patient is having what? Is having what? Is having it's reflecting as if it were the patient's left hand, right? Isn't it? So that's it. Just what? It just in what? In giving a sensory illusion that the this part of the body the patient is moving is actually the affected side, and that might help in what? In what? Renetworking the brain to understand that okay, uh, pain relief needs to be what? Needs to be achieved. So I will go to the next slide. I have many other things. So the basis for what? The main basis for this physiological basis of what? Of the use of neurotherapy is because of what? Because of presence of some certain network neurons that are called the mirror neurons in the brain. Those mirror neurons are located actually here in inferior frontal gyrus, primary motor cortex, inferior parietal lobe, occipital lobe, right? This is from one of our papers also that we talk about rehabilitation of severe impairment in motor functions by what? By utilizing the role of mirror neurons. So these are the areas of the brain actually that those network of neurons that are called mirror neurons, they are called the social brain. And they are responsible for what? Mirroring people's activities. Perchance people are sitting, four of us here, and somebody does yawn. Another person may also yawn. All others may also yawn. And if you are walking around a place and somebody said, I'm feeling like just urinating, others might. So just because of the mirror neurons, this is what possible. What makes this actually possible. So just like you look yourself in the mirror, you just see yourself. That's just mirroring actions, right? So it's actually an important network of the brain that we can use for managing our patients in so many, be it in spinal cord injury, be it in stroke and what have you. So that's the basis for what? The basis for mirroring. It's called the social brain as well. So these are the ones I talk about are the exercise-based interventions or movement-based interventions. But we also have what? We have behavioral therapies, the use of cognitive behavioral therapy. So why do we do this actually? Because if you remember, initially in the course of the discussions, I think at the beginning, I said patients with central postural pain usually come down with what? It's actually associated with anxiety and other emotional disorders like depression actually. So CBT is actually been known to very strong evidence in helping people with anxiety and depression. So the main thing that CBT does, it helps what? In changing thought patterns related to pain. So what you do, you just do like a talk-based therapy, just motivation intervention. You sit down with the patient, talk to him, what actually causes his pain, and you just try and find out situations where the pain gets what? Exacerbated, or situations where the pain gets relieved, and times when this pain gets exacerbated or gets provoked. You look at and ask the patients areas of his life that are limited now because of this pain. So you can discuss and find a way with inputs from the patients. Okay, how do you actually see that the patient accept this? Actually, live even though live his life to the fullest or as independent as you can, even though the pain is still as what he still feel the pain. So one of the things that distinct from one study by Charlotte 2024 is that it actually helps improve self-efficacy and motivation during rehabilitation. So one of the things apart from relieving the pain or relieving anxiety and depression, it also helps improving people's self-efficacy, patient self-efficacy. Yeah. Patient's ability, okay, I'm not, even though I have pain, I think I have the ability to live through this pain and do everything I want. So it helps that. It also increases motivation. Yeah, it helps the patient, okay, these physiotherapists are doing their best for me. So let me also encourage them out and also put more effort to see that they do the best for me. So it's also, so aside from just pain relief, it also helps in improving patient self-efficacy. The patient, if you have self-efficacy, okay, even though I have pain, I think I will be able to do this and that and that and that. So it's also both self-efficacy and also motivation. The next one is the acceptance and commitment therapy. In the acceptance and commitment therapy is just to make the patient accept their own condition. And this is actually being used when the patient, any improvement in the pain is actually limited. You've done all rehabilitation, you've done all treatment you've done, but there is no any improvement in sight. So you can institute these ones and make the patient accept his condition. And even though the condition is still there, the patient can be able to live his life, do his activities of daily living, even participate in the life activities and engagements, right? Even continue his work, assuming he's just a carpenter or maybe a mechanic, and he needs the hands to earn a living. So definitely, this is actually really important. So there are 6 components of this acceptance of commitment therapy. One is the acceptance. The patient has to then also cognitive diffusion. In the case of cognitive diffusion, the patient needs to some extent remove his thoughts from the pen. Then also value-based actions and you ask what ask the patients to you and the patients can plan action that actually very very valuable to the patient's life. Let's say the patients does play sports, maybe table tennis as his leisure activity. So you encourage the patient to accept that, to accept his conditions, and see ways he can be able to still do that those activities within the what, even though the pain is still present. So contact with the present moment. So also observe ourselves. Observe ourselves is like removing patient completely remove step back and remove himself from his own conditions. Yeah, it's his condition, but he has to really realize that okay, he he himself is actually different from the what? Different from the condition. Because if you now continue to think that okay, this pain has what become part and parcel of him, that will prevent him from what? From doing meaningful activities in his life. He will always be overwhelmed by the feeling of that pain. Then the person has to also be committed to what? Taking actions. I think this one of the studies from Hughes et al. Uh, on on pain. Then the next one is the sensory training, and I think we need to pay careful attention to this. It's actually an important part of what we do for our patient, we can do for our patient, because it's actually very easy to use. And in fact, it even comprises the components of ways we assist our patients with pain, not only those with central postural pain. One, texture. We can use this texture. We can ask patients to what? We can use textures, different textures. We can use different surfaces, right? We can give probably maybe a bottle of water just to feel the texture. We can give another maybe something, a box like this, the patient to feel maybe many different textures. The patient let the patient practice feeling all those textures. That might what help in what help in also reorganizing the nervous system, the pain system actually. Then temperature also. We can also make the patient to feel different temperature, maybe cold, warm temperature, or hot temperature. The patient inside his hands inside a cold temperature again. Yeah. So to be able to feel different temperature, that may also help in what reorganizing the pain system. Then touch localization, right? We can touch the patient, ask him to close the eyes. We can touch different parts of the body and ask the patient to localize those areas. That may also help in what reorganizing the pain system. And yeah, we also can do what proprioception test. We can move a particular joint upward or downward and ask the patient to localize the what direction of the movements. That will also. So according to OFEC et al. 2023, is a randomized controlled trial they did, and those a couple of years ago. What they found out, the use of sensory retraining actually alleviates pain. It also improves tactile threshold detection, and it also improves measures of gait and balance. So you can see not only pain itself and other sensory abnormalities, it helps. It also helps in what? In other measures of activity, measures of measures of activity actually. Yeah, measures of activity. Like for instance, gait and what? And gait and balance. And the reason because what the brain wants if someone has problem with the nervous system is what? Is to be engaged in an activity. Just anything that can stimulate the brain. So anything that can stimulate the brain can help in organizing the system. I think that's all about this part. And here are my references. Apologies. I think they look really very small. Zefa. Hello. Hello. Zefa. Hello. Hello. Please, is anybody with me, right? Hello?
Yeah, with you, sir.
We can hear you.
Can hear you. We can hear you, sir.
Okay, thank you so much. So, do I go to neuroplasticity or we are going for a short break? I don't know.
Short break.
Short break, sir. We need to pray.
Okay. So it's okay. I'll also pray and come back. But I will not go offline. I will just put off my video and so please.
Thank you.
Okay.
It's okay, sir.
Thank you, sir.
Sorry, I'm just back from with little glitch. Please, is the presentation over, please? Hello? 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 Please, is the presentation over?
Oh, they went for
We can hear you, Dr. Ashiru.
You said?
We can hear you.
Yes, is it over or are we coming back? Is it
they
over
went
or we're
for a
coming back?
break. They will come
Yes,
back.
we've gone on break. We've gone on break.
For short break for prayer.
Okay, so we're coming back by 4 what?
Okay, the time was not given, I think.
Okay, thank you.
Hello. Are we all back? Can we continue now? Hello. Can you hear me, please? Hello, please. Can you hear me, please? Hello?
Yes, sir.
Baba. Okay, you can hear me. Okay, that's fine. That's fine. If you can hear me, it's fine. It's okay. I just want to find out. Okay, it's good. So, are we starting now? Can we continue, please?
Come on. It's as if they didn't come back from prayer.
Okay, Bas Dawa?
Again.
Okay, to fine. To bari mu jira. Bari mu
So you have to unmute yourself. Currently muted.
Okay, so thank you so much. I can hear you now. You can hear me, Joseph, right? And all the other participants can hear me, right?
Yes, we can.
Okay, so thank you so much. I think just to wrap up the last lecture, I think what I realized in the area of management of pain, easy rehabilitation, in particular in central post-stroke pain, and that what the literature even says as well, is that so far there is no any method, any intervention we can say actually. Actually, the evidence is good also. Most of the interventions actually they have very low evidence. And even if you look at them, some of them are even just 1, 2, 3, 1 or 2 case reports. So I believe the honest now is with us as clinicians, as scientists, as academics, to use the ones that we already have and test them to see whether how far they work actually. Yeah, but I believe that managing central postural pain should not be a headache. Yeah, because if you look at some of the interventions that I use, especially the constant inducement therapy, the sensory education techniques, they are easy to use techniques, and in particular, the task-specific training and constant inducement therapy is already been known to be good for inducing neuroplasticity during the ablation of motor function. So I believe that maybe our clinicians can take these interventions and isolations and trial them on their individual patients and see how far they work, and they can report those ones as case reports. Then number two is that I believe the way to also go is the use of hybrid therapy, whereby we combine different techniques for patients. We can use neuromodulation for the patients. At the same time, we are using exercise-based therapies and also the sensory education technique. So combining one or more could be one of the ways we can help our patients. But of course, like I said, the onus is now with us to see that as clinicians, we try and pilot those individual treatments, even though they are case reports. But let's see, because the advantage of a case report is that it can easily be applied clinically, unlike bigger randomized control trials or larger studies. The essence of case report is to give the clinicians a clue on what they can do instantly for their patients. So thank you so much. I think I can move on to. So I don't know if there's any questions concerning that, or I have to round off everything before I expect people to talk. The moderator, can I just go on?
Yes, sir, you may.
Okay, so thank you so much. Okay. So I'll talk about neuroplasticity now, and what I will talk about what neuroplasticity is all about. Then at the end, I will talk about neuroplasticity in relation to pain modulation, what actually happens. So what are the ways that those things happen, right? So maybe if I may ask, I think that should be my first slide. Right up here. Sometimes it takes time. Okay. Busy. Okay. Yeah, okay. My first slide asks the participants, what do we understand by neuroplasticity, please? Any person who can help us with that? Just give us a hint. And let us be a little bit interactive. Since I started, it was not really interactive, right? So if anybody can help with that, then we can. Okay. I'll just move on anyway.
Hello, sir.
No,
Okay.
hello? Okay, come on.
I think it refers to
It refers to the brain's ability to reorganize its structure, its connections, and its function based on changes with experience, learning, environment, and also injury.
Okay, thank you so much. I thought that Josefa, you are in orthopedics, right?
Yes, I'm in auto, sir.
Oh, you are in auto, right? So thank
Yes,
you so
sir.
much. I think one of my slides used auto to explain what neuroplasticity is all about. Yeah, is it auto? I use auto, so I will thank you so much. I'm happy that it's an auto person that actually attempted to contribute. Thank you so much for that. So we just go on. So the basis of understanding how the brain, the nervous system actually changes is to look at it's just possible to look at the structure of the nervous system, what actually they are composed of. You can see we have the cell body here, right? We have the dendrites, we have the axons, right? And we have the axon terminals. So those axon terminals are the ones that actually connect what is called the synapse, right? Just like the normal orthopedic joint that we have, the knee joint, the elbow joint, right? So here, the synapse is also a joint formed by the axon terminals and the dendrites. And for the purpose of what? For the purpose of exchanging information, transmitting information from one part of the neuron, from one neuron to another, and subsequently to another one, so that transmission of information can be seamless, right? So if you look at the junction, there's junction actually. So I'll just move straight. So neuroplasticity is also known as just neural plasticity. It's the structural. So when we say neuroplasticity, we are just talking about ways the nervous system modifies its what, either the structure or what, or the functions. So these are the two ways: either the structure or the function of what function. Its function. It can modify the structure. By modification of structure, if there are fewer cells, it can modify itself and increase what? Increase fewer, sorry, the number of cells. It can also what? Increase the connection. Yeah, the relationship between it and between one nerve or one neuron with another. This another, yeah. Or maybe increase the connections or strengthen the connection between one part of the brain and the other. So we'll talk about those things. So there are basically two ways that the brain can modify itself. One is what? The neuronal generation, sprouting, which is called the structural plasticity, which is something I just said now, and functional reorganizations, either to modify the structure itself or the function itself. So we'll look at them one after the other. So when we say, so when we talk about structural neuroplasticity, we are talking about the ability of the brain to physically change brain structure, or due to learning and experience. So there are ways that this structure can be changed, either by what? By learning and experience. And we get this learning through what? Through the physical exercise we give, or maybe through introductions of anything that can stimulate the brain, such as the neuromodulation and all that. So all those exercises that we give, therapeutic exercise, their main thing is what? Is to induce these changes that we are talking about. So one way we will understand the structure of the nervous system has changed is what? Is there is increased number of neurons, like I mentioned, increase in synaptic connections or strengthening of the synaptic connections, that the junction, the joints that connects between what, between neurons actually get strengthened. Just the same way you increase the strength of the quadriceps just to give the knee joint more stability. So there's something with the aid of exercise, with the aid of learning and experience, the synaptic junctions, synapse also what get also strengthened the same way musculoskeletal joints are also what get strengthened. Then number two is the functional neuroplasticity, the change in the what in the function. It can occur due to what synaptic remodeling following brain injury, begin to die. So one of the ways we get functional neuroplasticity is that the pre-existing neurons may begin to die, and when they die, new neurons form synaptic connections over time to recover lost functions. So it's not that the function is just being modified first. No. What happens is that the pre-existing neuron actually begin to die or die, and new neurons are what are formed, which was form new connections to take over those what those lost functions. So these are the two ways we can what's the heck as a whole? You just have to okay. So for the structural change plasticity, there are two ways that this happen. One is what they call synaptic plasticity, and the other one is called the adult neurogenesis. So in the case of synaptic plasticity, what happens that is the ability to make experience-dependent, long-lasting changes in the strength of neural connections. I think we mentioned this one much earlier. So in the synaptic plasticity, what happens in the synaptic plasticity is just to what? To increase the strength of what? Synaptic connections. That's what happens. So the nervous system actually modify itself in such a way due to experience, maybe that experience because of introductions of pharmacological interventions, electrophysical interventions, or maybe exercise intervention. They can what? That experience can cause what? Lasting changes in the strength of the neural connections. That's what they call synaptic plasticity. Then the second one is the adult neurogenesis, right? It is the concept that the brain continues to make new neurons. Yeah, when we say adult neurogenesis, it's the concept that the brain actually, as old as it is, even people that are older, 50, 60 years old, what those brain actually makes new neurons. So even if there is a loss of one neuron because of damage, injury, other neurons can also be produced. But of course, there is another thing also. Luckily, the brain has one thing. It's been created in such a way that it's been created with abundant neurons that we don't actually need in our functions. That's what the fact that they call it redundancy, redundant neurons. There are neurons that are just stay idle, they don't do anything because we have too many neurons. So even if a greater percentage of the neurons in the brain are lost, those can actually take over. That's the issue of this one. So for functional reorganizations, that's functional plasticity, neuroplasticity. There are three ways that it can happen. One is called the what? The equipotentiality. In equipotentiality, it means that when one area of the brain is damaged, the opposite side of the body brain will be able to sustain the lost function. So imagine we have two sides of the brain, the right and the left hemisphere. So if any part of the left is being damaged, probably similar areas in the right side can be able to take over the lost functions, the function lost by as a result of damage of those ones in the other sides of the brain. And this principle is called equipotentiality. We also have what we call vicariation. Vicariation is the concept that the brain can reorganize other portions of the brain to overtake functions that they were not intended to. Vicariation is that if you have a particular part of the brain that its main function is to carry out its particular functions, but then it happens that perchance that one part of the brain which control a particular functions got damaged or injured. So those ones that hitherto were only functioning to carry out a different function can also be organized to carry out another function. Just like in our day-to-day activities, if at our own place of work we have a particular person that carries out a particular duty, in his absence, another person can be delegated to carry out that duty. So the same thing, the brain also is very, very generous. It can also delegate another part of the body by modifying itself. So that's what's called the vicariation. Then we also have what's called diachesis. Diachesis is the concept that if one part of the brain is damaged, that damage of that part of the brain can lead to what? Can lead to what? Depression in functions in a very distant part of the what? Distant part of the what? That's distant part of the brain. But why? Because they are connected what? By similar or the same pathway. And that's the reason. So if one part is being damaged, is being injured, if there are areas in distant part that are connected with the same pathway, that area can also be different because other part it's just like if you have pain in the body, maybe you receive an injection in the buttock, for instance, that pain may be felt almost throughout the body, right? Because of the connections between different parts of the body. So the same way in the brain, if one part is actually being damaged, in as much as the connection between it and another distant part is the same, so that part is that function of that part is going to also be depressed. And I think probably this might be important in terms of interhemispheric inhibition, particularly in stroke. When one hemisphere is a part in one hemisphere is being damaged, similar area in another hemisphere can tend to inhibit, can override the functions of the functions of the other damaged hemisphere. So maybe if there is this kind of diathesis, it might help to normalize, so that there was even during rehabilitation, there may be difficult in the excitations of the two different neurons in two different hemispheres. Probably that might be. So neuroplasticity in the context of pain. So how do you understand neuroplasticity in the context of pain? We understand it in two ways. One, there is maladaptive and adaptive neuroplasticity. So if you look at the pictures I put up here, pictures from orthopedic field, these are maladaptive malunion, right? Yeah, you can see colors forming around the two joints. Why is it? Why did they actually? Why is it actually like this? So it's because even if you don't manage fracture, even if you don't reduce them, definitely colors will form. Yeah. So if you manage them, you are setting them at the right directions, and you heal normally, right? Isn't it? Just the same way you can see here. Here, because there is internal reduction here, you can see the metals here being used, right? So the parts of the bones are aligned together, and it is better. It is easier for them to heal, right?
For the interruption, sir. Your slides aren't.
And now what?
Your slide is not moving, sir.
It's not moving? No, it's moving.
Yes, sir. On the slide showing structural neuroplasticity and functional neuroplasticity.
What about now?
There's no change yet.
There's no change? Maybe I'll share it again.
Yes, sir, we're not seeing the screen.
Okay, so let me, I'll share now. Sorry, please. I'll reshare again, okay?
Okay, sir.
Is it on now?
No, not yet.
Not yet? Okay, let me stop sharing and reshare again.
Okay.
Okay. See, this is the one. I guess you can see it now, right? It's coming on?
Yes, it's working now.
Okay, that's the slide I have. And here the slide talks about neuroplasticity in the context of pain. So there are two ways neuroplasticity takes place, occurs in relation to pain. One is maladaptive neuroplasticity, and the other is adaptive. And I said, if you look at this picture at the left corner, that's an example of the maladaptive. I use orthopedics to give an example. So if you have malunion fracture, right? If I have malunion, what happens usually is because the two bony ends are not aligned together, and as such, callus will just form anyhow it wants, right? So I said, if someone had a fracture, even if you set the fracture or not, definitely callus will form, isn't it? So the same thing with neuroplasticity as far as it's concerned. Whether you guide it or not, if there's an injury, definitely neuroplasticity will begin to actually take place. Brain will attempt to organize itself. So if you don't, the treatment that we give, rehabilitation, are meant to what? Are meant to guide the neuroplasticity for the nervous system to organize in the right way, so that we get all the benefit and we get healing, we get improvement and all that. So if you don't do that, actually, what will happen is that there's going to be maladaptive plasticity. And we'll talk about that in relation to pain and what actually causes that. So if you look at this, in the right corner, what we have is that we have a reduced, an internally reduced fracture, and you can see the bones are set together, and the healing is already taking place in the right way, isn't it? So the same thing. What we do in rehabilitation is that after the injury of the nervous system, reorganization actually begin to take place. But we can actually direct that reorganization to go in the right path, so that we get improvement if we will now institute or begin to apply treatments, right? Especially as early as possible. The same way, if you have a blind man, and that blind man, you just ask him to walk from one place to another, maybe to cross the road. Maybe by the edge of the roads, there are gutters and a drainage system and all that. So if he doesn't have any cane just to guide him, or maybe but anybody to guide him, he may end up falling into that gutter or into that ditch or the drainage system, isn't it? But if he has a cane or someone that guides him, he can be able to feel the ground, and if you feel that okay, here there is a sign of any ditch or any gutter, you may be able to navigate around and you will not fall into that. So there's something, if you give treatments, you can direct that, right? So we'll see what I'm talking about when I talk about pain. So in the case of maladaptive neuroplasticity, as far as pain is concerned, there are three things that happen actually. One is there is what? Increased peripheral sensitization actually occurs. Central sensitization also occurs, and cortical reorganization also occur. And when these three occur, what they do is what? They tend to what? They tend to chronify the pain. By chronification of the pain, it's just to what? To make the pain to last longer. So there's not going to be healing. And that's why we have chronic pain. One, because of what? Because of maladaptive plasticity. Because there's increased peripheral sensitization. These are the three phenomena that actually take place. Increased peripheral. So in the case of increased peripheral sensitization, what happens is that if there's in increased peripheral sensitization, there is lowering of activation threshold of nociceptors by inflammatory substances. So, nociceptors actually, the nociceptors tend sensory neurons actually. If there is pain actually, okay, if there is lowering of activation threshold of the nociceptors, it means a repeated pain stimulus can what can cause increase on activation, increase on sensation of pain, and even chronifications. That's making the pain to actually become long standing. So that's what we call peripheral sensitization. And what causes that is what is the increase in pro-inflammatory substances. If there are inflammatory substances at the side of the injury, that will help in causing increased peripheral sensitization, which will also causes what? Lowering of activation threshold of the nociceptors. So any small stimulus can also actually be interpreted as actually pain. Then the next one is the central sensitization. In central sensitization, two things actually occur. One is the what? Synaptic plasticity. We talk about the synaptic plasticity, right? So when we talk about synaptic plasticity, it's also about increasing the strength of connection between neurons. And I showed in the first slide that the neurons actually synapse with each other, make a junction with each other through what? One of the neurons will bring its axon terminals, and the other one will bring its dendrites, and that's why the synapse actually takes place. So what happens is that as long as if there is long potentiation, that's increasing that strength of the connections of the neurons increase to occur, that will cause central sensitization. So the sensation of pain is also going to actually raise. Another way is what? Structural changes that actually take place. One, activation of microglia. So in adaptive malplasticity, there is activation of microglia, and this microglia actually causes increased expression of pro-inflammatory substances. The ones I mentioned earlier on, the interleukin 6, tumor necrotic factor, what they call it, nerve growth factor, and all that. So it actually causes what? Increase in expression of this, and these are pain substances. So the pain sensation actually tend to get raised. Then there's also axonal sprouting. Yeah, sprouting means just growth of the axons and all that. Yeah, and it actually happens because to help make more connections with other neurons, and that will also cause increase in pain and loss of inhibitory neurons. So neurons that actually inhibits neurons also is also caused by what? When there is loss of inhibitory neurons. So two things happen in central sensitization. One, synaptic plasticity and structural changes, and all of them lead to what? Lead to pain chronification, increase in pain sensation, and even making the pain to become long-standing. So Another way this happens is what? Is cortical reorganization. Yeah. So the same way we have the cortical motor map, what we call the motor homunculus. We also have what? We also have the sensory homunculus. Yeah. So after a brain injury, what happens is that after injury of the nervous system, in the sensory homunculus, just the same way we have the motor map where the parts of the body, different parts of the body, the foot, the lips, the eye, the hands, and are represented. We still have similar one also, where all these things are also represented in the sensory cortex here, which is actually here, and that's the motor cortex. This is the motor cortex. So they also represented the map, right? So if in maladaptive neuroplasticity, what happens is that size of the map, let's say I have pen in the hand. So what happens is that in the case of expansion of the somatosensory cortex, area that represents my sensation of my hand in the brain gets to expand. It also increases in size. So when it increases in size, the pen tends to also become long-standing, and the pen intensity even increase as well. So what is what we call the chronification of the pen as well. Another thing is what? Decreased volume of prefrontal cortex. Prefrontal cortex actually helps in pain modulation, helps in decreasing pain. So if perchance there is an injury in the nervous system, the volume of the prefrontal cortex might also decrease. So when it actually decreases, it can also lead to chronification of pain, or what is called the maladaptive neuroplasticity as far as pain is concerned. Then another thing that also causes cortical reorganization is when there is increase in activities of the amygdala. You remember, there is decreased volume of prefrontal cortex, but in relation to that, there is increased activities of amygdala, and amygdala controls function to control fear. So if the amygdala activity also is also associated with fear, it's associated with fear. So if imagine there is increase in activity of amygdala, that means fear will also increase, and fear also increases increases pain sensation, right? Then another one is also increased activity of the anterior cingulate cortex, which is also associated with affective component of pain. So if there is increased activity in the anterior cingulate cortex, the pain also get sensation of pain also get increased and even long-standing. So adaptive plasticity, as far as pain is concerned, results in what? Results in chronification of pain. Results in what? Making the pain to become long-standing, and probably also make the sensation of pain become much higher in the case of allodynia and hyperalgesia. So how do we now ensure that we prevent maladaptive neuroplasticity? And that's what we do as physiotherapists. You may remember when I talked about interventions for the central post-stroke pain, I mentioned the use of TINES, the use of other neuromodulation techniques, therapeutic exercise-based interventions, including aerobic exercise, CMT task training, I talk about them, sensory education, and of course, also the use of So all this intervention, we are using them to help guide the neuronal organization, the reorganization that takes place in the brain, either structurally or functionally. So that's what we do. So if we do give this intervention to help induce adaptive neuroplasticity. So in a case where you don't manage pain, the pain can cause what? Can become long-standing, can become more severe and all that. So what we do in adaptive neuroplasticity is there's a normal plasticity that takes place to help improve functions, either motor functions, either pain sensations, just to help improve the function of the nervous system, which includes motor functions, sensations, cognitive functions, and all that. So as far as pain is concerned, we can achieve adaptive neuroplasticity. That's the right one. That's just like similar to correct union after reduction of rhabdocytes. So the same time, if we want to achieve that, we need to also align the plasticity that takes place with with the use of neuromodulatory techniques such as normal electrophysical techniques, exercise therapy based, and so forth. So I got this one from one study, which talks about the mechanisms, a little bit of the mechanism of adapting neuroplasticity with the use of aerobic exercise in post-stroke pain. Sorry, my eyes are now I'm becoming older anyway, sorry, don't worry. So you can see now, post-stroke pain, what happens in post-stroke pain pathophysiologically is that the anterior cingulate cortex here gets impaired. That's what happens. That's what happens. It gets actually impaired in that. And there is also what? There is also inhibitions of what? Opioid receptors here. Yeah, and also decreased expressions of opioid receptors, and also on endogenous opioids. And there is also decrease on the elevated level, increase in expressions of the brain drive neurotrophic factor. Unlike in motor functions, actually in motor functions, what happens is that a recovery is brain drive neurotrophic factor actually its expression actually gets elevated, gets increased. But in the case of pain, it actually gets reduced after. So it actually gets increased. Sorry, it gets increased, but in motor function actually it gets decreased. Yeah. So another way is what is activation of the microglia, and as we mentioned earlier, if there's activation of microglia, it tends to what to encourage expression of pro-inflammatory factors, which are pain causes substances, right? Right. So then after exercise, to get exercise pain relief after exercise, aerobic exercise, I think in particular here, there is what? There is cortical organizations. There is cortical organizations in terms of what? Promoting synaptic plasticity. What's the other one here? Sorry, my eyes has become somehow. So I didn't even see it anyway. And also what? Increased expressions of endogenous opioids, and also increased expressions of pain receptors. So it's actually the reverse of the pathology that takes place initially. So also increasing what? Increasing activations of anti-inflammatory factors, such as the one we mentioned earlier, right? The one we mentioned earlier. Then, yeah. So there's also inhibition of microglia activation. We know that if there is activation of microglia activation, it also causes increase in pro-inflammatory activations and expression of pro-inflammatory factors, right? So what exercise does is just to reverse this pathology. I think that's what it does. So, Bigawa? So these are the ways actually it happens. One is that regulation of synaptic plasticity in anterior cingulate cortex, not context, it's cortex place, not context. Modulation of the adrenal opioids, it increases expression. Modulation of brain drive neurotrophic factor. In this case, it does what? It reduces its expression. Unlike in motor functions, usually what happens is the increase in expressions of the brain drive neurotrophic factor. But in the case of pain modulations, the brain drive neurotrophic factor gets reduced. Its contraction actually gets reduced. Then inhibition of what? Cholinergic receptors, which are signal system expressions. Then inhibition of microglia aspilation, which we mentioned much earlier. I don't know whether this is the end of my slides. Let me check. I think that's the end of my slide. Sorry, please. So please, I think that's the end of my talk today. And if there are people who have questions, we can. Did I close? Okay. It's like I stopped sharing, right?
Yes, you've stopped sharing.
Oh, okay. So maybe if there's any question, I can still share again. So please, if there's any question people can ask, if there's any contribution, people can make contributions. Thank you so much for your time. Yeah.
Thank you for the presentation, sir. And thank you
Yeah,
for
thank you. You're welcome.
dedicating 3 hours out of your day to make this presentation. It was indeed refreshing, and
Yeah, thank you
I
so much.
hope. Okay, the floor is now open for comments, questions, and contributions. So if you have any, you can drop it in the chat box, or you can make the comment directly on the webinar.
Otherwise, we call it a day.
Questions, comments, and contributions.
Nobody will ask me questions. That means people didn't really. Okay, it's fine. It's fine. Maybe they're saving my time. So, do I ask questions if in the absence of people asking questions? Maybe I can ask questions as well.
Yes, I think you can go ahead and.
Yeah, so I can see, okay, the participants are still here, so I can ask these questions. So now, what tool can you be used? Can you actually use to screen for neuropathic pain? Neuropathic, yeah, pain due to nervous, nervous system pain. What tool can we use actually? Maybe anybody can just answer the tool we can use for that.
DN4.
No? Yes, you are saying something, Aisha Abubakar, right?
Yes, sir. DN4 tool.
DN4. So please, can you tell us what it's about, and how do you know that someone only uses DN4Q? How do you know that someone is having Okay. I think maybe you need to go home and digest it, right? Yeah, Aisha? Okay. I think she has turned off her. Adam, I think wants to he maybe contribute. Okay.
Assalamu alaikum wa rahmatullah.
Wa alaikum assalam wa rahmatullah.
I want to appreciate
What are you
especially
eating?
I'm taking my dinner actually.
Your dinner, okay? Yeah, we have not. We just done our answer. Anyway, it's okay. It's fine.
Yes. So I want to appreciate the entire presenters.
Thank you.
For finding time to make these educative presentations, particularly those of today. I shouldn't be biased because this is coming into the neurospecific presentations pertaining to pain. We all know that I would like just to say a few words. Assessment is very important component of patient management. If we don't do real assessment, then we cannot manage the conditions that our patients are presenting to us with. Then the second one is just a bit of maybe a contribution pertaining to the pain management. Now there are some technological interventions that are proven to be effective pertaining to the pain management. That's maybe talking about the wearables, whereby you can be able to wear some maybe sensory stimulators, maybe like the insoles, so that they can be able to stimulate and regulate the pain pathway. Then other things we have like the virtual reality, the use of the robotics. They are all proven to be effective in pain management, functional improvement also, and overall quality of life improvement. So thank you so much. This is just some few things that I want to pass across. Thank you so much.
Thank you for your contribution. So any other person? Maybe I'll
Yes, sir, we have a question in the chat section from Dr. Mubarak Muhammad. He's thanking you for the invited presentation and is asking if a nodal TDCS or cathodal TDCS can be used against pain. Which can be used against pain, and how could it be used?
Okay. Wow. That's 1 million naira questions for me anyway. Yeah, I think in our, let me check. I will share our sorry, I will share our case report here. I'm sorry, please. I'm coming. I will share the case report here on cathedral TDS, right? Okay. Sorry, please, I will share I think it's good I share the, where is it, please? Yeah, then guys. Okay, guys, I've seen it. So I'm sharing our case report actually. So I think it's an opportunity for me to share.
It's PowerPoint.
PowerPoint. Okay. Okay, you can see it, right? PDF is sharing.
Yes, you can scroll down. You can scroll it down. We can see. Just
You
scroll
can
it
see it,
down.
right? So
Yes, we can see. Scroll down. We can see.
So let me just get to the case presentation there. Sorry. Okay. Okay. So you can see in our intervention here, what was used was another TDCS, right? Yeah. So, but the thing is, I'm not really very sure whether cathedral TDCS can be used, but I know that we can use another TDS for the for the what? For the no for the its regional side actually. Then we can also place the use a cathedral TDS for the contraregional side. That's for multifunction actually, but I'm not really very sure whether both can be used. But I know in this our case, what was used was the another TDS. But can I will check. I will check the literature actually. I think I didn't care to actually look at that, but yeah, I know for sure anodal is used, but I don't know for anodal. But I think Adamu use TDCS. Please, do you have anything on that? Adamu?
Yes. I initially I used the wearables for my research, not the stimulation.
Okay. But do you have an idea whether a cathodal TDS can be used for pen?
Yeah, actually, most studies they tend to report the anodal stimulation form.
Yeah. Okay.
I think that's the most commonly used. Perhaps maybe the cathodal maybe is used for other purposes also.
Okay. Yeah, but unless if bilateral TDCS is used, so for the regional side, another can be used, while for the contralateral side, cathedral can be used. But I don't know. It's like I've seen Muhammad Ali, right? Is here. Muhammad has done something on TDS. He's okay, TMS. Okay, but yeah, some similar anyway. Muhammad, are you here, please? I've seen Muhammad anyway. Muhammad in Hong Kong, right? He has gone offline, I think. Okay, it's fine. He and Samani have gone online. It's late in the night. Okay, it's okay. Please look at the literature actually, but like
I'm there, sir.
Okay. Do you have idea whether cathedral TDS can be used for pen? Cathedral application of TDS, please. Do you have idea? Is Muhammad with us, please? So it's okay, Mubarak. I think the only thing I know is the use of the another TDS. I even checked the literature. I couldn't find any yet. But if I see anything, I think we.
Sorry, I muted myself.
Okay. What did you say?
Okay. I muted. I didn't know
okay.
that.
Okay, you can hear, but you can hear me, right? You heard me, right? Did you hear my question? Okay, Jibril knows with us, please. Okay. I think Mubarak, you can check that. You can check that in the literature. But what we have here is there is another. I think Adam, who has also used that, has also buttressed that. And even in our cast report here, it's the use of another TDS, but I'm not. But if you have ever come across the use of Mubarak, can you share with us if you come across the use of Katoda?
Yes, sir.
Okay.
I think theoretically, sir, am I audible?
Yes, we can hear you, Mubarak.
Okay, I think theoretically, sir, we know the anodal TDCS lead to the stimulation and depolarization of neuron, which increase the cortical excitability and therefore modulate pain through descending pain inhibitory pathway.
Yeah.
So I think anodal TDCS should be favorable for acute pain, while cathodic TDCS should be favorable for chronic pain.
That's theoretically, right?
Yes, theoretically.
Oh, okay, that's fine.
Based on the previous knowledge that we have,
Okay. Well,
I
thank
think
you.
that should be the case.
Thank you. So please, any, okay, you want to say something again?
Yes, I can't see it for stroke pain, or I saw
For
some
motor function, right?
on migraine.
Migraine, okay, for migraine.
Yes.
Okay. Maybe that's a question of trying it and see whether it works then.
Yes.
It's okay. It's okay.
There
So
are some meta-analysis on migraine and
migraine, right? Okay, that's fine. Okay.
And then also on sensory pain.
Okay, and okay, that's fine. So any other thing, please?
Any other questions, comments, or contributions before we round up?
All right, I think we can round off it down, right?
Yes, there aren't any questions in the chat room, and nobody is indicating that he would like to talk. So, in the absence of any comments, I would allow you to continue with your work. And we appreciate you for taking time out of your busy schedule. I understand that you're busy preparing results for submission and whatever. We thank you, and we thank all of our presenters for today and for the previous week for their time and their efforts. So we thank you very much, sir.
But thank you so much to everyone also for coming online to listen to me. Thank you, and have a nice day. And good night to those in other time zones.
Okay. I would also like to extend the appreciation of the Kano State chapter of the Nigeria Society of Physiotherapy and its education committee and other partners and participants who have taken time to come online and learn with us. And we hope to see you next year in the first quarter CPD program that we are planning to have. It promises to be as exciting and enriching and stimulating as this one has been. Thank you very much. We are currently working on seeing that all of participant-related submissions from the certificates to videos and to resources that our presenters have shared with us reach you within the next 1 or 2 days. And so be on the lookout. As soon as I share them with you, I'll let you know in the workshop group. So thank you very much. Have a wonderful weekend ahead. And once again, thank you from NSP Kano.